Hello, you can see there our speed during operations. It is quite normal situation in Ostrava. It can be motivation for you. So good morning, ladies and gentlemen. I hope that yesterday was interesting day for you, that also gala dinner was interesting for you, and we can start our program. Vicky, I would like to ask you to introduce two patients.
Thank you. Good morning, everyone. The first case is the first case in our handout is a 47-year-old woman with anatomical variation of the right maxillary sinus, also known as a Heller cell. And since 2013, she has bilateral nasal obstruction. Rhinoendoscopy with physiological findings. And on CT scan, we can see the partial opacification of the Heller cell on the right side. According to our radiologist, he said that it can be subseptic maxillary sinus. So indicated is supraterminal antrostomy on the right side. It's operating theater number 5. And another case on operating theater number 7. It's a patient with septal deviation and turbinary hypertrophy and with nasal obstruction about 10 years. On the rhinoendoscopy, we can see septal deviation on the left side and subluxation on the right side and inferior turbinary hypertrophy. Septoplasty and radiofrequency turbinoplasty is indicated. So we can switch on the operating theater. Thank you.
Thank you. It is really severe deviation, so Niels Abrams decided to do it from open approach. So we can go to OPE Tanya. Can you hear me?
Yes, I can hear you, Pavel. Good morning. Good morning, everyone.
I don't hear you.
Oh, you can't hear me?
Yes. It's better now.
Okay. Yeah, good morning to everyone.
Endoscopic view, endoskopický obraz, we don't see. A ten zevní dejte do rohu, prosím. Yes, okay.
Yeah, you can see it now? Excellent. Okay. So the patient has been introduced and we did the decongestion and we'll have a quick look through the nose. So we're on the right side. We have the inferior turbinate. She's got a little spur here. But she doesn't really have problems breathing, so we'll leave it where it is because it doesn't bother us for our surgery. Then we have the middle turbinate, middle meatus, which looks nice. And on the opposite side, there's a little bit of mucus there, but otherwise the mucous membranes look healthy and nice. She's got quite a bit of inferior turbinate hypertrophy here, but we're not planning to do any surgery on that. So we're going to start our middle meatal antrostomy and with an uncinectomy, and you know that there's different approaches that you can actually do to do your uncinectomy. Yesterday you saw the anterior to posterior approach, and I'm trying to show you the posterior to anterior approach now. Can I have the Frias?
Mohu poprosit o snímky, abyste dali do jednoho rohu CT, jestli máte.
So you can see the posterior rim of the uncinate process here quite nicely. You can see the ethmoid bulla here. And the advantage of the posterior to anterior approach is that you can actually you always work away from the orbit. And in some cases, the uncinate process will be stuck to the lamina paparacea, backbiting. So there's a high risk of injuring the lamina paparacea when you do the anterior to posterior approach. So this approach is quite nice. So we'll just have to try to sneak in here. And then we slide in behind the uncinate process with a backbiter. Sorry. So the endoscope is still a bit cold, so we get this fogging. I'm sorry for that. So you do 2 bites and one slightly oblique suction. And then I take the ball probe, please. The ball probe. And then you can use a ball probe to mobilize the uncinate. And then I take the 45-degree cutting Blakesley. And you cut along the uncinate. And then you'll be able to remove it. Straight Blakesley, please. Straight one, yes. And the blunt one, not the cutting.
Dejte prosím i druhý obraz z druhého sálu do pravého třeba dolního rohu, ať vidíme.
Okay, suction, please. So now we've removed the upper part of the uncinate process. You can have a look if you can already see the natural ostium of the maxillary sinus, but there's still some remnant of the uncinate left, so I'm going to remove that. I need the ball probe again, please. And can you put on the bended suction, please? So here we've got the horizontal remnant of the uncinate. The one that's not that much bended. And we can mobilize it and then remove it in a second step. So we'll find the natural ostium behind that. So I'll take the downbiting forceps, please. We have a downbiting one.
Žírátko dolů.
I saw it somewhere. No, I saw it somewhere.
Žírátko dolů.
Yeah, that one. Yeah. Thank you. Staff here is really excellent, I have to say.
Tanya, we interrupt you now, and we will go now to OP7, and
Okay.
we will follow you on our screen. Yes, so
that's fine.
Niels, can you start your operation, please?
Yes, I will. Yeah.
Můžeme změnit, prosím vás. A zase, ať vidíme i druhý operační sál. Niels, yes, can you hear me?
I can hear you. Can you hear me?
Yes, we can. Can you start, please?
Yes, we're already on the way. I'm taking out the cotton swabs. I soaked with cocaine before, so I'll take over the camera for a second. What you can see here,
Endoskopický pohled od doktorky Hildebrandt. Taky dejte do rohu, prosím vás. Do rohu. Prosím vás, teď hlavní obraz, septoplastika, všecko ostatní dejte do rohu. Ale z obou sálů operačních.
Okay. So the caudal end of the septum is luxated, as you can see on the camera. And if you go to the other side, it's completely deviated to the left. It looks like it's fractured. There's a vertical line. And when we pass it, we can see it's also deviated with the spur behind it. Okay, so I give the camera back to Jacob, and I'll start with the hook. And we'll clean out the nasal hair for a good view.
Maybe that I can comment this, because when I started with septoplasty, I always operated through these hairs here. And if you want to get a good view, I can recommend you first take the time and do away these hairs in the visa from the entrance of the nose. It's first, you have a better view, and second, you can always, when you prepare this, when you're in a situation, you can always think about the operation, what you will do, something is changing then, and this is a very meticulous part of the operation in the beginning. So I teach them all to take first out the hairs from the nose, and very meticulously. It's also in endoscopic surgery, because always the endoscope becomes dirty when you go through the hairs there. And it looks a little bit funny, but it's very important for the operation. You will see this.
Jakube, nechte rozsvítit prosím velké světlo, jestli nebude vadit panu doktoru Abramsovi. Na ten sál bude asi lepší obraz, ten endoskopický. Zkuste se zeptat.
So you get now a good overview of the anatomy.
You can turn this more up, maybe? It's not turned.
Můžeme, prosím vás, obrazy z obou sálů, zevní a endoskopický. To znamená, doktorka Hildenbrand také zevní pohled, ať tam vidíme.
Maybe when you turn your light off, does that help? Or?
Jestli operační světlo nemůžeme na tom sále číslo 7 rozsvítit, že by bylo lépe vidět tím endoskopem?
Niels, we can go now for a few minutes into opposite operating theater. So můžeme prosím vás přepnout na doktorku Hildenbrand. Endoskopický pohled.
Endoskopický pohled ze sálu číslo 5, prosíme.
Jako hlavní. Yes, Tanya, can you hear us? Yes?
Yeah. I just want to show you that because that's what we saw on the CT. So we've got some mucus coming out here.
Yeah.
And you can quite nicely see that we have a look into, I'm just going to turn this, sorry. So we have the hollow cell here.
Yeah.
And we've got the maxillary sinus here in front of it. Okay. So, and there's quite a bit of mucus in this hollow cell, and that's what we saw on the CT scan as well. So what I'm going to do is I'm going to remove the partition between this cell and the rest of the maxillary sinus as much as I can. And then we're actually done. So if you want, you can move to the other theater, or we'll stay here and I'll do some surgery.
You can continue. We can go there now to OPE, to opposite OPE, and
I'll take
we will follow you.
Yeah.
Yes, you can continue. Můžeme
Yes,
přihnout, prosím, zase, ano. A zase pohledy, ať máme i z druhého sálu, oba dva zevní i endoskopický. A tady také obraz zevní ještě, ať vidíme pozici. Ale z obou sálů, prosím.
Okay. You let me know when we're back. The scissors, the small ones. So we prepare the alar cartilage now. So you got the one alar cartilage here. Hang on, I'll make it dry a little bit. So that's the medial crura. Okay, then we turn to the other side. And prepare the other alar crura, the cartilage.
If I compare the situation with Germany, in Czech Republic it is divided, and usually at most departments is performed only septoplasty and not septorhinoplasty. In Germany it is quite normal procedure that septorhinoplasty is done by ENT doctors. So they are familiar with this approach. Yeah, but in Czech Republic I think that many of you, and can I ask, who has experience with external, with open approach for septoplasty? Who? How many? Jürgen? Not? Yes. Who? Yes. Yes, so not many, not many. So I think that it can be interesting, this open approach. It has many advantages, because you can, you will see that,
we use this in every difficult septum.
Every difficult.
Yeah. No, that's a very difficult septum. And I think you cannot do, you have great problems to do this with a closed approach here, this operation.
And now we switch to scalpel number 11. So can you hear me? Now I put a chisel under the skin of the columella to protect the medial alar of the alar cartilage.
That's very important. If you don't do this, so you have the problem that you often incise the alar cartilages, and so that was invented to do this, to chisel or other instrument, and then you cannot do any harm to the alar cartilages, as you see afterwards.
Now we perform the inverted V incision.
Approach can be different, because Peter, when he indicated this operation, the indication was for closed septoplasty. When I saw this patient, my preparation would be open approach. Yes, and
we're done with this one. Can switch back to 15.
Everything is possible.
You get many problems with the closed
approach. I need the little scissors now.
You can do that, but it's a great problem.
There are some limits. With open approach, there is less limits. And you?
Yeah, well, we had this discussion yesterday, and just, 30 seconds ago, I refrained from So it's perfect to do it this way, okay? Advantages, disadvantages of the different approaches. If you go for an open approach, you diminish the projection and protection of the nose. And currently, we see that there's a severe septal deviation. We don't know in which shape the cartilage is, okay? Whether there's a horizontal fracture, vertical fracture, whatever type of, incomplete fracture, whether we have mechanical stability in the nose or not. And there's some kind of Damocles.
Wait a minute, that's the ligamentum pitangui, which you would just see here.
Go ahead.
So the ligamentum pitangui there.
So there, in the upper left picture, we can see Tanya, how she destroyed the septum between maxillary sinus and Haller cells. And Niels, can you explain us what structure can we see there? Because we don't know what it is. I think that many of doctors, they see it for the first time.
I was just looking for for one instrument we're missing on the set. Actually, I don't know why. It might be for the central sterilization. I'll try it this way. Give me something to point. We have the alar cartilage, the right one, and the left one. And you see the septum is right here, so it's not in between those two. It's not subluxated, it's luxated. And now you can see the form. The septum moves this way, so it's completely tilted to the side.
There is vertical fracture.
I assume it's a fracture. The patient told me yesterday he did never have a trauma. Can you give me 2 of those, please? So what we use to spread the cartilages now are the 2...
said that
I don't know the word for it.
These problems after COVID.
Clamps.
Clamps, yeah. What we're missing here is the Aufricht-Elevatorium, which would help a lot right now. Can you hold this with one hand? And I would like the Edson-Brown forceps.
Niels, Pavel says he has an Aufricht there, so your scrub nurse should be able to help you.
Okay. Do you have an Aufricht elevatorium? Do you know what that is? Aufricht? Aufricht?
Můžeme přepnout, prosím, teď na sál druhý, ať nám Tania něco řekne. Tania, can you explain what are you doing, what was done, please?
Yes, I think we're almost finished here. We had quite a bit of fun getting a lot of mucus out of this cell. Well, I had. Everyone else in the theater didn't, I think.
A obraz také na opačný sál, ať vidíme stále, co dělá druhá strana. Okay. Yes, you can continue, sorry.
Yeah. So we can see the remnants of the Haller cell. I've removed most of the anterior wall. And here we can look into the maxillary sinus with healthy normal mucosa. I will try to remove a bit more of this inferior part, but I think then we'll be done.
Yeah. What instrument did you use for it? For removing of the bone? Can you show us what?
Yes. I used this 45-degree through-cutting Blakesley. Yeah. I think it's really nice because it's bended and it's cutting, because the advantage of the cutting instruments is always that you don't tear the mucosa. Because if you use the blunt instruments, you can obviously break the bone, but by removing it, there's a higher risk of tearing. So I quite like these cutting instruments. And on the right side, I use them usually backhand, so turned around, because then I don't have, or I have more mobility with the instrument. And yeah, you can reach quite far, and then just
we can see it.
Away the bone, which is quite nice. And no tearing of the mucosa at all. Yeah, but I think that's about it. We're just going to clean, give it a good wash, and then we're done. Any questions?
Any questions? Petr Matoušek, would you like to do more surgery now?
No, I think the same way how Tanya did it. So I think
Victor,
it's perfect.
are you satisfied?
It was a really nice approach, so we could see different approach from uncinate process because Tanya did the resection from posterior to anterior. Yesterday I tried to show you the resection of uncinate process with sickle knife. So we use the approach from anterior to posterior. There are a lot of differences how to make the resection of uncinate process, but we should preserve the little bit the upper part and preserve the frontonasal duct, because if you have scarring in this region, you can have mucocell after several years.
That's fine.
Thank you, Victor.
Okay, so if everyone's happy, I'm happy, and
Yes,
hopefully
yes,
the
no
patient is
question.
happy.
I think that it was very nice operation. So, and
Thank
what
you.
are you going to do now? Will you use?
I'm just gonna give it a wash, and then I think about putting in a pack. In Germany, we usually put in packs because our patients are not very good in tolerating a little bit of blood, or well, at least not the ones in Freiburg. So I usually put in a pack for one night, and yeah, then we're done. I would give her some steroids, topical steroids, and nasal douching post-operatively.
Yeah.
And that's it.
If you want, you can use absorbable pack. We have a Posicep, I think. So if you want,
great.
put it, you can.
Yeah, okay, we can do that.
Mayor, I won't do a packing here. I will not do a packing here inside. Nothing rinsing, nothing to do. It's a self-healing process for me.
I will put Gelaspon there, I think.
Yeah, nothing. Okay.
The opening, Tanya, the opening of maxillary sinus is relatively very anteriorly.
Yes.
Are you not afraid of nasolacrimal duct damage?
Because I haven't punched there. I haven't put a punch in, so no. I know that it looks quite anterior.
Yeah.
But I haven't punched there at all.
Yeah. Okay. So Tanya, we will follow you. Thank you. We can.
May I say something to the approach? Stamberger told me then when I was there, only to open the sinus, the antrum dorsally, not ventrally, not with a punch there, only with the Blakesley dorsal. So you cannot do any harm to the lacrimal duct, never.
Yeah, and I haven't used a punch or anything. It's basically, it kind of, some of it broke when I used the Blakesley, but I'm not afraid that the duct is in there.
So Tanya, thank you. A můžeme přepnout na druhý sál a budeme sledovat stále, co Tanya dělá. So Niels, we are back again.
Okay,
so can you
perfect.
explain what was done?
Yes, we have the alar cartilages here,
Yeah.
the caudal end of the cartilaginous septum, and you see it's already coming from this point to the middle now. We're building the upper tunnel on the right now, and found already the right level here. So I'm pushing this over, and we always start on the concave side because there's less risk for damage.
Here's the instrument you were just using. Is it like a section Yeah.
It's a cottle preparator with a sharp end, and later on, if we're able, we use the blunt end.
So Cottle said that the sharp is for the bone and the blunt is for the cartilage.
So now we see, I believe there might be a fracture because it's getting tougher to prepare. And there's a lot of scarring back there. So we're at the back side of the fracture now.
You see above there's the Aufricht instrument here inside the nose. That's very important because with the Aufricht instrument you can, there's a small Aufricht, it's a real Aufricht, but you have a view on the back of the nose. And that's very important because if you want to put the septum in the middle, you have to see the back of the nose afterwards and to sutures, maybe.
When I started my septoplasty, it was done only under local anesthesia in sitting patient. Yes, but it was not completely removed. It was quite different things. And then I saw different position of doctor and of patient when it was done under general anesthesia. The patient was lying so, and many doctors, they are staying and they rotating their body and so. And there I visited many clinics in Germany, Austria, and the best position is really to sit, normally sit in this position because it is good position for your body to sit on very normal operating chair. To sit so, not to rotate. Patient should adapt to your position, not to rotate so, not to stay so, because you have only your body and you should spare your health. So it is the best position. It is good to have some assistance because sometimes you can work with two hands, not only to fix. It is better to really to do. It is my opinion to do in this position. Jürgen, do you agree?
If you look at my knees, you know this. I operated always in standing position years before, but today, since I think 15 years, we do everything, thyroid surgery, everything in sitting position, and that works well.
You can see here, there's a lot of scarring at the maximal point of the deviation. I'm at the concave side here. And now I use the sharp elevator to dissect those fibers, and sometimes the scissors, switching back and forth.
So when we start to teach our residents with septoplasty, they're mostly obliged to look at the open rhinoplasty or open septoplasty because that is good for the anatomy. You get a so good look at the anatomy and you get more understanding for the septoplasty and for the septum pathologies if you do it with an open approach here.
Septoplasty and turbinoplasty, they are performed very often also in snoring patient. Can I ask Misha? Is there Misha Masarova? Should be performed screening in snoring patient in all patient, or can you direct to do septoplasty, or what is our approach at our clinic?
Okay, I think there are 2 points. First,
do mikrofonu blíže.
Patients undergoing septoplasty often snore, and I think it's very important to have complete history, patient history, focusing on sleep disorders. And these patients should undergo sleep monitoring, like limited polygraphy. It's the first point, yeah? To find out if the patient just snore or if there is also obstructive sleep apnea. And the second one, many of these patients with obstructive sleep apnea are treated with positive airway pressure,
elevator.
but they are often not compliable. And one of the reasons could be, for example, deviated septum. So also before treatment with positive airway pressure, septoplasty should be done. That's my opinion.
Yeah.
Questionnaires before.
Of course, this is the first step.
My opinion, septum deviation plays not a role. I never do a septoplasty before we do a CPAP or so on. We have a sleep laboratory. We do have 6 beds with sleep. I've never done an operation on the septum for snoring or for obstructive sleep apnea. Professor Pirsig said it all in the 90s, 70s of last years. If someone has problems with breathing of the nose, he has to be operated. If someone has no problems with breathing of the nose and he has a sleep apnea, then he must have a CPAP, not an operation. That's what he wrote, and that's right for today. It's my opinion.
Okay, so we got one side
We
now.
do no septoplasty because if you're a patient with real sleep apnea, it's a risk. And you know that only maximum 10% of the patients you operate on a septum can get better with their sleep apnea, and I've never seen that a patient after an operation of the septum can be better tolerate a CPAP or a BPAP. That's not right.
But he doesn't
Do you
agree.
have the anatomical version of the Edson-Brown?
Some deviation. Sorry. Some deviation is septum. He can intolerate the CPAP, and we saw it, and we operated them, and then the pressure we use for treatment of obstruction is definitely lower. We can see it. Yeah, it's.
Yes, that's true. But many of that patients have nasal symptoms. Many of them.
If they have nasal symptoms, it's no problem.
Yeah, but
what's the problem if someone have a CPAP of 9 and afterwards you get a CPAP of 8, and you have it's a risk patient afterwards? You look at the great. We have a literature. No one says that it's a great advantage to operate someone on a septum. We don't do this, and I tell you, we have a year around 700 patients in our sleeping laboratory, which we put with a mask, and I've never done a septoplasty for them. In this case, if this patient would have will have problems with breathing, we will operate him. Yeah. But if he don't have problems with operation, I told a total face mask and give him, and I will not operate him. Because if someone has an AHE from 40 or so on, and he is 100 kilo, 120 kilos, it's a risk operation. And why shall I do it? Shall I do this?
Achim, you wanted to add?
Yeah, so two different things. The one is that in a rhinology published review regarding like sleep surgery type of thing, septoplasty was supposed to improve the symptoms of snoring in about 10%, which is not much. However, with the well, it is. Yeah, that's number one. And number two is in the area of CPAP and the question whether we do tongue implantation system, if they don't accept our CPAP therapy, reducing the applied pressure from like 14 millimeter mercurium or whatever it is in English to a lower value will improve the compliance of the patient, may help to get him actually on the CPAP. Okay, so those two things. And because you have congenital septal deviation, like this patient reports us not having had a trauma, but you know it's not a normal septum in any way, they may not be aware of what is supposed to be, you know, an even-sided breathing on both sides. So that's a question of how I do my history taking and stuff like that, and whether I point out it's like what your colleague told us about questionnaires, and that, you know, if you have chronic rhinosinusitis, your snot score might be 15 because they have lost touch to reality, what is supposed to be. Anyway, I mean, you need to have a decent reason to do a surgery, and there should be one, okay, and not operate on like physiologic septal deviation.
And maybe I'd like to add to this patient, we were talking about the injury. In his history, there was no injury, but he has told us that it was performed transnasal adenoidectomy when he was 11, and he thinks that his problems started after this procedure. We don't know, but
rough surgeon.
Yeah.
Charles?
But you see, it's the difficult part of the operation, because that's a problem where when you have a close approach, I think we will have many problems to solve this problem here, to get around the deviated part of the anterior septum here.
If you have a close look now, you can see the fracture line. Do you see it?
Yes, yes, we can see.
And right behind it, that's the maximum point of the deviation.
Yeah.
So I try to...
And the point is, if you start with this operation, don't try to get behind this deviation now, because it will end in a disaster. You must, before you go further on, you must divide the septum from the dorsal part of the septum. You must look first, now take the Marsing knife. We will do it, I think, in some minutes, and then you can expose the dorsal part of the septum. Otherwise, that will end in disaster with a large perforation.
No. There it is. That one, yes. No, that one, perfect. So what we use now is the Marsing knife.
We operate the septum, all septums like in a cooking book. We have recipes for this, and that's the way is normal. And we do every step is clear what he has to do now. That's not by what he thinks in this moment, but he works our style of operation here. And you can work much with the scissors, as you see here, with sharp instruments. That's what I've learned in my career in the university clinic. So there, we take blunt instruments, and that's always the mucosa ruptured, and you have to take. It was 40 years ago. You have to take sharp instruments in this situation. You will not succeed with a blunt instrument here.
Yeah. Any thought on the preparation section unit, you know? The preparation section?
No, we didn't use this. It's much too sharp in this situation, because the suction device, the sharp suction device, that perforates at once. So this suction device must be blunt. You see, it's a very difficult operation. Sometimes it's, if you must have time, it's a length. Sometimes you have 1.5 hours to prep to operate this difficult septum here. But it's worth to do this. So yeah.
We have the fraction lines here in the front, this one and right here, and that's the maximum point. And I made the incision, the vertical one now, to relieve the tension here in the front, so I can pass behind it.
The Marsing knife, Professor Marsing described it, and we use it in every operation here to the posterior chondrotomy, or to solve these fractures here.
Jürgen, can I ask you to have your presentation, and then we follow the the surgery, and if there will be Niels, when there will be some important points, we can switch on the theater. So, Jürgen, please. Jakube, my teď budeme mít... Dobře. Yeah, thank you.
So, I want to talk to you for another interesting topic here that you not often hear in your clinics. It's the dental sinusitis. The dental sinusitis is a borderland between ENT. This is normal ENT CT, what you get a little bit more to the bottom, but this is normal ENT CT. And this is what a dentist or maxillofacial surgeon sees. Is it the pointer here? Ah, yeah. Oh, here. This is what he sees, on that what we see. We are fixed on the osteometrial unit, and they are fixed to the teeth. And normally there's no connection between all or both disciplines here. So I make this to understand what happens in dental and rhinogenes infection. I made these pictures here for you. And you see what we're looking for is the osteometrial unit, and from the osteometrial unit we think that all the inflammations go down or back to the frontal sinus, to the sphenoid sinus, and to the maxillary sinus. And that's what the dental surgeon or the maxillofacial surgeon sees. He sees this infected periapical tooth here, and the infection goes up. You see here, that's quite another pathogenesis of the disease here, and we must see that this disease also exists in our daily practice. We see, I summarize it here, the dental sinusitis is from bottom to top, and the rhinogenous sinusitis is from top to bottom infection, and that's quite different here. The problem is that we don't have a unique ICD for this infection. So it's, in my eyes, it's underestimated. It's subsummarized on this ICDs here. Where is it? Oh, yeah. Here, other chronic acute sinusitis, other chronic. We use normally other chronic sinusitis, but it depends on the surgeon, on the doctor, what he wants to write here. And we made in our practice, we do many dental operations, and I showed you afterwards, and in our practice, nearly 20% today, it's gone more, of all one-side operation have a dental background. Mostly we have iatrogenic causes. It's here 65%, you think 2/3 are iatrogenic causes. It is measurement during canal root treatment, then lancing of the maxillary sinus during canal root procedure, persisting fistulas. I'll show you some pictures afterwards, dislocation of dental roots in the antrum, and so on and so on. Then this is a picture you see here. Here is a white oral antral fistula after an extraction of there's a cone beam CT. In the practice, we have a cone beam CT. The cone beam CT, I will tell you, that's 0.5 millimeter resolution, and the slides. And this lady, she came last week in our practice. She had extracted the tooth in the left upper jaw and got 3 implants, the same procedure. And the dentist doesn't see that he produced white or antral fistula, with she complained about fetid smell and so on and so on. And we have to close this oral anterior fistula on our operation then. That's non-iatrogenic causes. That's not so much. So quite different is the germ spectrum. When we, don't tell you about Raynaud's infection, you know this. But if we have dental infections, we have normally anaerobes and we have normally Aspergillus, and not so much Staphylococci or so on. That's quite different because the patients tell you when they come, the anamnesis is very important. They said once, I have a foul smell in the mouth and the nose. That's the main topic when they came in the practice. One-sided foul smell. No? So that's the anamnesis here. Raynaud feeling of pressure in the maxillary sinus, feeling of pressure in the eye, pain of mild symptoms, but no dental pain. There is no dental pain. Don't think that they have a dental pain. Normally, it's a slow process and it produces no pain. So that's what we see in the endoscopic view. That's this pus going from the middle meatus. It's very disgusting gas. Then you see here swollen processus uncinators here. If you specialize with this topic, you will see at once that this is not what we are. We have no polyps, we have nothing. That is a dental sinusitis. And you have to look at the mouth for the teeth. And we first use always a sonography, because the combination from mouth disgusting of foul smell and sonography gives us the diagnosis. And you see here a back wall. Who is it? I lost the word. Enhancement. Yeah, that's it. That's one enhancement here, and that's typical for sinusitis. You see on the other side we don't have this. So these 3 points which shows us that here is a dental sinusitis, and the anamnesis with tooth extraction or so on. And here you see also a cone beam CT. You can see here, this was the cone beam CT from the patients before with the sonography. And you see here the root is, there's a large radicular cyst which bulges in the sinus here. And that's the cause for this infection. You see, and we have in this point of view, we have all the pictures we go through, and normally if you get from a CT for ENT, it will stop here, and it could be that you will not see the problem of the teeth here. There's another picture here, also cone beam CT with this you will not see in your CT when you get it in your ambulance. And you see this is a dental sinusitis, and you see here periapical cyst, which causes also this sinusitis here. This is a young lady. You cannot see it really because she got an infection of the orbiter here by the infected tooth, but you see here, it would be very difficult to decide if this tooth is reliable or is for this infection here. And so you must, if you want to ask your radiologist for a diagnosis of dental sinusitis, you must tell him he must take small slices, 1.4 millimeters, and he has to show the whole upper jaw to decide if they have a dental sinusitis.
Sorry, můžeme ten obraz dát, prosím vás, do levého dolního rohu z toho operačního sálu? Ten obraz operačního sálu. Yes, thank you. You can continue.
So this is a patient we operated last year. She has, as you can see here, she have had abscess in the frontal brain, and the cause was infected tooth here. So what we did, the neurosurgeons, they opened here and opened the abscess, and we first opened the maxillary sinus, and then we did tooth extraction, and you see here were many roots of the teeth, and they did a severe infection of the sinus here. And this, what you see in a normal CT, you can see nothing. That's a normal CT we get. A normal we got, what we get is 2 to 4 millimeters slices, and you cannot decide from 4 or 2 millimeter slices over a dental infection. Even orthoponogram or the dentist cannot say if there is a dental infection the cause for the one-sided sinusitis. It's only 85%, and other statement shows that our series suggests that a normal dental exam and normal dental radiographs do not exclude a dental sinusitis of source of maxillary sinusitis. But so you must have a good imaging to decide if there is a dental sinusitis. Here you see another sinusitis. You can see here very precise where the rupture to the sinus is and who it goes from the bottom to the top, this infection here. You see this also here. You have this infected tooth here, and here is, and we have to extract it and do close the our anterofistula. Normally, it's short. If you go to maxillofacial surgeon, he will extract the tooth, then he will rinse the sinus for many days. He will give you antibiotics, and after 14 days, he will close the oral anterofistula. It's a long procedure, normally 2 to 3 weeks. No? Yeah. What we do, our concept is a single-stage procedure in case of dental infection. We do the endonasal surgery, we do tooth extraction, or we do endodontics or apiectomy, and the closure of the oral anterofistula. The advantages are clear. We avoiding the normal ostium. You must not do a real fess. You only have to open the anterior sinus. You have to make a bright or wide opening of the maxillary sinus. You must not, or it's not allowed to operate in the sinus by itself, because you can do harm to the Schneiderian membrane. That's a very interesting and very important membrane for the implantation. It's a mucoperiosteum. If you do harm to the Schneider's membrane, they have very much problems to implantation of new teeth there. You have less after treatment. Otherwise, we have no after treatment. I'm not a great friend from after treatment. Here, we don't also need no rinsing. I don't think that rinsing brings anyone any sense after operation. And you do not have to give antibiotics. So that's what we do. That's the operation. First, we open the anterior ethmoid. Then we open here with this from Stamberger with this instrument. We open the sinus, and you see what we see. You see here. We see pus, and we don't go with the instrument in the maxillary sinus. That doesn't make any sense. There's anything you have to do. Afterwards, we do the tooth extraction here. This was the tooth. You see here's the Ohfeld root material here. It was the cause, it's a so-called Gutta-Percha-Stift. And he is looking in the antrum and the bottom from this maxillary sinus. And afterwards, we do a Raymond flap to close this hole here. This was the tooth you see here. He causes the infection of the sinus. So that's the flap that I showed in the picture which I draw. You see the flap we use. That's a mucoperiosteal flap for Wehrmann. It's a very common flap we use every day, really every day, every week. And that's the working horse. And that's who looks at afterwards when we close this oral enteral fistula. There are different other flaps. Is it Axhausen flap we use not so often. And the palatinate flap is from Pichler. That's very nice if you have an open end here of the tuba alveolare, then you can use this. He's good, very good blood supply in this flap here. So, to come to an end, what is our message here? Dental causes make a high percentage of one-sided inflammation, nearly 20%. It's an infection from bottom to the top. We must think otherwise as we used to think. CT and automograms normally not sufficient for diagnosis. The best approach is a one-stage endonasal drainage of the maxillary sinus and removal of the dental focus, what we do by ourselves because I'm a dentist. The oral maxillary fistulae must close with a defined flap. The Schneiderian membrane is very important. Don't go with an instrument in the sinus. And the ENT doctor is very important to make a sufficient drainage to sinus before or after implantation or often to treat an infection or to prevent an infection. Thank you very much.
Jürgen, thank you very much for a nice presentation. I think that we have a lot of questions. But now we can go to OP and then we will continue with discussion. Niels, we are here again, so can you explain us what was done?
Yes, dry one. So we took out the spur at the end. We have a look now at the left side. It's completely free now.
Yes, and what was done? Yes, we can see it. And did you resect some part of something? I don't know.
Yes, let's see. I'll show you the nose first. Okay, we didn't have to do anything on this turbinate. It's very small. We did radio frequency on this side because it's the larger one.
Yeah.
Now let's enter the septum. We didn't finish the front part yet. I left this for the end. Okay. Can you hold this, please? We opened the fracture line here. That was the first maximum point of the deviation. Behind this we had a high deviation and we had a spur back here, pushing it over to the side. So what's left for us to do now is loosen the attachment at the nasal spine and pull the septum, which tilted backwards to the front again. And then we can see if we need to do more resection at this point, or if we can fit, if it fits back together. I don't know that yet, but that will be my next step, okay? Yeah. So we're done with the turbinates, and I'm done with the posterior septum, so I'll go to the septum at the front now. Okay, scissors. See, there's the scarring, the process of scarring here. I'll cut those scars.
You can see there's no perforation in the mucosa, and that's the only what you can only. I think that's a great advantage of the open approach here now. You can see anything, and you can really
add some brown.
Do a good preparation. That will you not. I think that it could not be solved really with a closed operation. This one.
It's a completion of the columella.
You can use both hands.
Must be very radical. You must mobilize like anything.
Yeah,
if you fear to mobilize something, you will not solve this problem. You must mobilize the whole septum. Anything of the septum must be mobilized here.
Okay, now the front septum is loose, okay? The part that tilted to the side, I can move it to the front now.
Now you can see that the septum goes in the middle when you have got, if you have preparate all the scars and mobilize the whole septum.
When I started my career, there were no septoplasties performed. It was performed in Czech Republic resection. It was used knife, Belanger knife, and only small part of anterior part of septal cartilage was preserved to support tip of the nose, but posterior parts were removed.
You see here, he must now divide the lateral cartilage from the septum, because otherwise it will not go in the middle.
There's severe scarring up here. So what I would like to do is to realign the septum at this point. So I will stabilize this with a PDS foil, Morsing's knife.
It was Pavel, it was a Kilian operation you did, huh? Kilian operation.
Yeah.
Yeah, that's...
Yeah. And later, when septoplasties started in Czech Republic and Slovakia, people, they didn't understand that we should distinguish between Kilian's resection and septoplasties. And some people, they removed totally the whole septum, including this anterior support of tip. And Dr. Sičák from Ružomberok, he said that it is Carpathian type of resection. So they of course, there was no support, so the tip was decreased, and funny, but sad for patient.
So the problem we have here now, the scarring goes right up to the upper septum. And I try to resect the scarring because the cartilage is in double layers here. And there's a lot of tension in here. Scissors.
I'm persuaded from without open approach, it wouldn't be possible to do it in good way.
We discussed it yesterday, and we thought that it must be an open approach.
Okay. Okay, so I have a look. I have to hold myself. Hang on. Okay, we come closer here now. That's better. So I will suture PDS to the septum now, and afterwards I will straighten it out more by using the ritzing technique and loosening the tension from the right concave side. Scissors. Also, I need to loosen the tension up here. And you see the septum is already coming to the middle now. It's not in perfect position yet, but it's a lot better.
It is not possible to believe that septum will be in correct position if you get this correct position only with suture. There must be no tension. So it should be in good position spontaneously. So it was what Jürgen said, that it is important to warn it to release the whole septum. Yes, all this.
When I was a young resident, they told us we cannot do very good septal surgery. And then we put the foils out, and the septum deviation was also. And then
you can see the septum is in the middle
came and said, yes, we have to put the new tamponade. on the other side and wait 2 weeks, and it will correct, but it will never correct if you don't do a good operation. And the patients were crying for pain if you put after 2 weeks, 1 week after the operation, new tamponade in the nose. It was not so nice.
There's actually 2 in here now. I don't know, but 1 should do. Okay.
There is somebody from Ružomberok, lady? Yes. So, you don't do any more Carpathian type of septoplasty?
No, no.
And do you know this name? Do you
I heard about it.
Have you heard about it? Yes. So yes, it was a joke, but the second thing for me was important that you want to preserve mucous membrane. It is important not to do perforation, but it is traumatic for surgeons. So Dr. Sičák and Maroš Kováč, they don't say about perforation, but they say about drainage window. It looks much better, and you have not so big trauma. If you do perforation, oh, what can happen? But it is drainage window.
Petr just asked me to put my feet in my ground because I was advocating in favor of a closed approach, and now the question is, why did I think so? Well, it's more difficult, that's for sure. However, you spare the ventral parts, so the ligament combining both medial parts of the lateral crura they are. So, and by this you achieve to get preserved a bit of projection and protection. As long as you don't know whether there's any vertical fracture in the interior part of the cartilage septum, there's a question whether you need to have cartilage from like the ear or rib to replace this ventral part, because it has to be of mechanical stability. And by preserving everything that you have, you may think that the likelihood of taking off a transplant is slightly less, okay? Having said that, it's more difficult to get from the right side over to the left side and then across this extreme septal deviation.
Yes, maybe
and you have a higher likelihood of having a tear in the mucous membrane, okay? So that's something that you have to take into account, and I think you have to use the approach that you are most comfortable with. But the fact that we are like, trying to get to the edge on the one side, and the other side, I was expecting to get an extracorporeal septoplasty, so take the cartilage out, change the direction, or get a transplant, stuff like that. Then I would love to have the ventral part being intact. Okay, and that was just the background idea. Yeah.
You will not get, you won't have a problem with the projection here, we'll see. Now he puts a PDS foil there. There's a cottle clamp here, and then we will suture it, and you will have an ideal projection in this case, I will tell you.
The problem is we didn't have a projection here in the first place because the septum was completely luxated to the side. As Tanya said yesterday when she saw the patient, there was even like a groove on the back of the nose. It's like a saddle beginning. And that was because the septum was not in the middle, it was not in the nose anymore. So putting this back will actually benefit the outer shape of the nose also for the patient.
How expensive is this PDS foil?
I think 100 euro, roundabout. And you must have a perforated foil, because if you don't have if you have a closed foil, then you got infections. And we know that under the foil, cartilage will be produced. That's what there's research done. Under the PDS foil, there will new cartilage be generated. And so we often use PDS foil in this type of surgery. We have many of these difficult noses. And you see that's ideal how now the septum is. And you see we have a good projection, better projection than before, because there was nothing, no projection. The columella was empty, and we will, the caudal septum will be brought to the medial alar cartilages afterwards. We will stitch them together, and I think that looks very good what he's done now here.
What do you think about Medpor implants? Medpor implants.
Don't use anything in this things. We don't only use PDS. We normally use PDS sutures. We use PDS foils, and this is special. This is a vicryl suture. We do this because it's better to knot here. The knots will fasten better. Normally we only use PDS for anything. We don't have any other material in OP. Only PDS sutures. And that's PDS ideal, or even in silent surgery and so on, it's an ideal material. And what is also important, the foil is not allowed to, if you have a perforation of the mucous membrane, you may not put the foil on the side of the perforation. You get an infection at once. You must always on the other side where no perforation is.
I think
it's interesting. I haven't seen it.
Have to do revision cases to take the Medpor out.
Microphone, please.
I started with this some years before because this is a problem. Who will you solve it? The problem is that the anterior part of the septum goes down over years. And this will not happen with this PDS foil because it's very stable. And under the PDS foil, you will have new cartilage. That's it. And you will see patients years after they have a stable, good septum with a very good projection. Yeah.
Price is 100 approximately.
Around 151. Not so much, but if you see this year, it's again so good results. And in my opinion, the only way is this open approach to do this.
Yeah.
That's problem. We do many rhinoplasties. So we do a week 2 or 3 rhinoplasties, and that's for us a normal approach here. Yeah.
Achim, and do you use this material for septoplasties in some difficult cases?
Well, the answer is yes. If you have a situation where you can't get any cartilage anymore, so the preference being like ear cartilage, rib cartilage, whatever. However, if you have no chance to get that, then this is a possibility. Or if you have an acute infection, because we don't have what is called bank cartilage, so after septal hematoma, you know, in the very old days, or septal abscess, and we don't want to use the ear cartilage just yet because we just want to get the infection out, hematoma out, okay, and play for time, knowing that it's likely that we have to do a revision later on. Then stabilizing the remaining cartilage with this kind of foil is another option for us, okay?
Is special foil for septoplasty, or it is general for
this
other?
Foil, we use it also in orbital fractures.
Yeah.
It's very, if it's not so large, if it's too large, if it's a small orbital fracture, you can use it only when your fat takes out and you put it on the bottom of the...
And if you want to find it in catalog, what is the name, officially name?
There are 3 different PDS foils available, the thickness being 0.5, which is the trauma one, 0.25 and 0.125.
That's it here. He shows it here.
Yes, we can
That's
see
perforated.
it now. Thank you.
Yeah. Oh, so 0.15. Okay.
There are several PDS was a larger one and a smaller one. It's only it's good. There you see that's configured for orbital fracture here. Yeah, from normally.
Scissors.
Niels, afterwards you have to show this cottle clamp, with the spikes there. This clamp has spikes. This was introduced by Cottle for the beginners when they put the foils in. And that the foils don't, if you are a beginner of the septoplasty, if you want to stitch the foils to the septum, the foils go down. And so Cottle invented this instrument to clamp the foils between this. Yeah, you see here, that's it. They are and we use it to stick it together. So we have you see? Yeah.
We have it also.
But you don't use it. We have it also had in the.
I use it sometimes, yes.
That's good for beginners to stick the foils together.
This foil is on both sides or only on one side? Both sides.
On one side, the foil now, on the left side, on the former convex side, because I will incise the cartilage vertically from the other side to straighten it out afterwards.
And what we will do now, that's also a change to the other, we will now put the foils inside, Doll foils, because the Doll foils will stabilize. I don't know if he wants Doll foils or other foils. We put the foils very early in the nose, because with the foils you can stabilize this the situation very early.
How many stitches do you use for it?
I used 3 so far, and now it can't move anymore, so I'm looking if I need to add more at certain spots, and I think I found one way I can stabilize it more.
What size of needle do you use?
This is a 5/0 Vicryl suture.
That's P1.
A small needle. Let's
yeah,
see.
It's a Vicryl P1. Or was it P3? I think a P1 is.
Can you show us original packing if you have?
Yes, 1 second.
Yeah. Thank you.
Types P1 and P3. P3 is a bit smaller one. If you sutured perforations of the membrane, P3 we use for this one here.
Do you have any questions to Niels or to somebody? No questions. Dr. Knížek, no questions? Victor, at your clinic, do you use this open approach or not?
Usually not for septoplasty, but if Dr. Meislik make the rhinoplasty, sometimes he used this open approach. So this approach is really nice. So you don't use the antibiotics, Niels?
I hope we gave perioperative antibiotics, so see how the septum stands now?
Yeah.
Correctly, we do single shot antibiotics for the operation.
Okay, so that's the position of the septum now.
Yes.
It's right in the middle and stays there if I go away. Okay, so I'll fix it up with transfixture sutures. And within the nose, maybe Jacob can show you, it's all free now.
Yes, we can see it.
So on both sides, and I will put in the splints now to stabilize, and then I will reimplant the cartilage, which I will prepare now, and then I will start suturing up the nose. Okay.
We always do reimplantation of the output material there, and that's for me very important. And then you stabilize now the situation with the foils now, not at the end of the operation.
See, there's if you see the profile, there's.
We can see it.
Okay, so There is a tip support now. Okay. Okay, the blue ones.
Did you fix it to spina anterior, the septum, with some,
Not yet.
with some?
No, you don't have to do this.
Not
We don't do this at all because now the septum is without. This is standing alone in this way, and you don't have
to better
suture
the
it.
projection of the nose. No.
Not necessary. We'll see. He will suture it now, and then it is so stable. And the PDS foil makes it very stable afterwards.
Okay, so let me see what we took out. There should be a glass platter in here, and the lower one. What is it? It's also, yep. Oh, yes. So we're inspecting now what we took out. Mainly bone and some cartilage. Scalpel, 15. It's not much cartilage here. There's some more cartilage here. So let's see if we can straighten this out to reimplant. I don't want to reimplant deviated parts.
I missed during the operation time when you removed it. So I was maybe not concentrated, and I don't know when you removed this part of cartilage.
Yeah, during the talk of my father, I kept on working and I took out some parts, mainly the bony parts. Yeah. The cartilage I took out at the very beginning when I had to open the vertical fracture.
That's what I said. You must took out every deviated cartilage or bone, and then you must. But we also have to reimplant it afterwards. That's what Professor Heusing always teaches us, that you have to reimplant all what you take out to get a mosaic form, so that you get a good stable septum afterwards.
Perfect.
Otherwise, you will get a flattering septum. I've seen it in the nose, that it's always flattering if it only took this material out. And you see that's good to take now, to have the foils inside, because when you now reimplant, otherwise you are a little bit in fear that will dislocate. But if you have the foils inside, to stabilize your reimplantation procedure.
You hold it really close.
Can you show us the picture of the nose inside? We don't know, we don't see where is the foil now. On the left or right side, I don't know.
Hang on, you see the septal cartilage here?
Yeah,
The foil is on the other side.
Yes.
It's right here, okay?
Yeah, I can see.
So I already re-implanted a little bit of cartilage here. Up here, there's still cartilage.
Yeah.
So I'm just filling up the lower part. I think that should do.
Well, now it is better not to have their drainage window.
Okay.
Yes, nice.
Now I can close it, and that's where this comes in. It's directly in position, okay?
Yeah.
Forceps afterwards. It's good stabilized. So afterwards he will now use the tongue and groove technique. He will do the tongue from the septal cartilage in the groove from the medial alar cartilages, what will be done now. So you stabilize it in the middle. That's the so-called tongue and groove technique.
Scissors. All right, here we go. I had to take out some more scarring. Okay, now I need the PDS. This has 2 needles. You just cut off the one at the very end, okay? Like... Scissors.
We don't see what Niels is doing now.
I'm just taking needle. So add some brown forceps. So this suture has 2 needles. I just cut one off at the other end, okay?
How long is this needle? How long is this needle? It looks very long. 19 millimeters. Yeah.
See, now the septum is fixed in between the medial crura of the septum alar cartilage. Watch out with your hand. Maybe take that away. I don't want to suture up Jacob.
Perhaps in between a question, when do you use a suture like an 8 to fixate the interior septum? Because he said that he was like moving the septal cartilage to the front to improve live projection and protection. So do you use this tool?
No, never. I've learned it in earlier times.
Osmičkový steh. Yeah. Sorry.
The secret of this operation is that you have mobilized that there's no tension in the nose, no tension at all. And then the problem solves. If there's anywhere is tension in the nose, the tension will come to new deviation. Even if you do a
8.
8 suture, then if this suture diminishes, then you have all the problem from you. That's my opinion. Yeah, it's different opinions, but that's my opinion here. So that's in the fixation and tongue and groove technique here now. You see the tongue of the caudal septum is going in the groove between the medial alar cartilages. And if Niels will put his finger on the nose, you will see what a good projection we have afterwards. Yeah.
And any thoughts about caudal extension graft or columellar graft, or as an auxiliary? If
sometimes we do this, yeah, really. if this, but here the whole septum was there. It was only deviated, so he could put the septum in the middle. And but if there's a trauma with a hematoma afterwards, then the normal. Sometimes the cartilage is not there. Then you have to put the extension graft or so on. But if you can, if you don't use it, don't do it. Yeah.
Because you know the American guys and quite a few facial friends, every time they use an open approach, they put in a columella graft as well to like get equal to the loss of projection that the approach brings. Yeah, to take this negative effect back. In the middle. Just that you are like have heard about this possibility in terms of that. Okay.
Ah, here. Perfect.
V vojenské terminologii bych řekl, že to je rozborka a zborka. Ale vy, co jste nebyli na vojně, nevíte, co to je. Rozborka zbraně rozebrala se a potom se složila. I don't know how to say it in English. What are you doing now?
I'm refixating the lateral cartilage to give it more stability. Normally I would do that before.
Including septal cartilage or
Yes,
only
yes.
including?
No.
No.
Lateral, septal, lateral.
Yeah.
We're improvising a little bit here, as I forgot to bring the full long Aufricht hook.
We will follow you and we will discuss about lecture of your father, Jürgen Abrams. Can we?
Sure,
Yeah.
sure.
So maybe we try to go back to the presentation. Maybe most of you don't know that Jürgen Abrams is der Ed-der. What does it mean? That you are? What is your education, Jürgen? Can you explain it? Because you are expert in this. In this way, can you explain it?
What do you mean? From childhood or from now? From my
now, from your study.
Yeah. Okay. Yeah, I studied.
I need a lot of water.
Medicine, and afterwards I studied. Dental medicine. I worked some years as a maxillofacial surgeon, but it was not. It was not a specialty for me.
So
and then I started ENT, and I think I love ENT because the best.
So he's expert in dental medicine and is expert in ENT. That's why he understands.
I'm a little expert in dental medicine. I hope to be an expert in ENT.
Peter, what problem we have with our dental doctors?
Yes, thank you.
Do we have any problems?
A lot.
A lot.
So there is a problem. One problem is that they are not familiar with CT scans. So they perform only, I don't know how to say it in English, OPG, orthopontograms. And if we perform a CT scan, we can see, or our radiologists can see some problem around radix of the tooth, and we think that it causes maxillary sinusitis, and so we send the patient to the maxillofacial surgeon, and he performs orthopontogram, and he tells us no way, that's not dental origin. And okay, we look at the CT again and send him back, and he sent the patient back to the ENT, and the collaboration is, I think it's a development now. In our hospital, I think it will be 3D OPG and or cone beam CT newly, and maybe they will use it more as a standard imaging in that. And I think then it will be better.
You believe?
I believe. Yeah.
I don't.
Definitely, every collaboration is about bosses. So it's about the boss of ENT and maxillofacial surgeon, but I think that our maxillofacial surgeons aren't so happy to collaborate with us, or they don't have willing to collaborate, because every collaboration brings you benefits, definitely, for patients benefits, but a lot of problems with your operating room, operating time, and so on. So
Jürgen, situation. Patient is coming with unilateral problems. You mentioned many methods how to diagnose. What can you use? Ultrasound, blah blah blah. So what can you say us? What is your approach to this patient? What method do you start with?
It's strictly described in the practice as this operation also. First, when the patient came with one-sided infection, we first look at the nose, then we do an ultrasound. If there is there an echo of the back one, and then afterwards we look at the teeth.
May I ask, does anybody have ultrasound in your office? One, yes, doctor? Yes, 2, 3. Okay. Ultrasound.
Yeah, ultrasound. We look at the teeth and the anamnesis. That's forgot. The anamnesis.
Teeth. So you immediately are able to evaluate the quality of
disgusting smell. That's the problem. The disgusting smell. This is anaerobes, yeah, and then you see disgusting smell. That's the four things. And then we are lucky to have a cone beam CT in the practice. We do a cone beam CT within 30 seconds. We have the pictures, and we can say at once that it's a dental infection. So then we do the decision. Normally, the teeth must be extracted, because if you have a large cyst, if I show it here, then you can do root procedure. Sometimes you must do a root procedure, but I do that not by myself. Then I send them to dentist because I don't have
extraction is done by
you. And what I said, we do one-step procedure. If you go to maxillofacial, surgeon he will extract the teeth, and he'll be rinsing the sinus since the water is clear. When the water is clear, we'll do the flap and do it. That's a procedure from 2 or 3 weeks. And they give antibiotics, amoxicillin. That's very silly, because amoxicillin is not for a dental infection. It is anaerobes. Amoxicillin do not work in anaerobes. So, and then after 2 weeks, we do first endonasal surgery. We open the anterior ethmoid. We open the sinus. We suck out the pus. And then we go to the mouth, we extract the teeth, we prepare this Raman flap or Axhausen flap, what there is, close the oral anterior fistula, and the patient goes back for home. And we don't, that's to emphasize, we don't use any antibiotics. No, Ibupas, Ibi Evacqua, that's my opinion.
Do you use this ultrasound for diagnostic of this dental?
No, I didn't use it for a.
What is the reason? Why do you use it?
I don't have experiences. I know it can be done by ultrasound, but I don't use it.
And Pavel Vrabec? No, somebody who has ultrasound. You, where you are from? From Brno.
I'm from Brno, Bohunice.
From Bohunice.
Yeah.
Do you use it for diagnosis of dental sinusitis?
No, we don't use ultrasound for the sinuses. Only for the neck.
What is the reason to use it?
We perform biopsies guided by the ultrasound from the tumors of the salivary glands or other tumors on the neck.
It's same ultrasound like for neck?
Yeah, we do ultrasound. No. We use ultrasound for everything. I think Achim will have another opinion as I, because the university clinics don't use this. There's a great discussion between the practices and the university clinics. We will have in some days we have a discussion there about this. I will show this the worth of ultrasound. The ultrasound machine is standing left on our examination chair, and I think we cannot work with the ultrasound machine in many things. Yeah.
Thank you. Now
you see here how the projection comes with SE suture. Now, if you look to the right and the left, you see the projection is ideal there, and now he sutures the right side, right side, and now the nose will become up by suturing the alar cartilages now. Yeah.
Does anybody have any questions to Niels?
I would like to ask, what are you doing when you have an infection?
The microphone.
What will you do when you have an infection with this PDS foil? Do you remove it, or you have to reoperate?
Absolutely. We take it out. That happens.
Thank you.
I didn't understand. It was for me not enough loud, and I don't.
He will take it out. We will take it out.
He'll take it out. Yeah, that's right.
So, Niels, I would like to thank you for a very nice operation. A můžeme sledovat v malém rohu a můžeme přepnout na další operační sál. There is prepared Jan Vodička to do endoscopic pansinus operation, and we will follow one side, not both sides, one side of operation. Vicky, very briefly to introduce patient.
Aha, tak bych chtěl.
Case number 8. And it's a woman with nasal obstruction and discharge and anosmia after repeated endonasal surgery, last one in 2015. And then she's in Everest study. It means that after indicated for biologic therapy. But there is a persistent anosmia and bilateral nasal polyps in rhinoendoscopy. And on CT scan, opacification of all paranasal sinuses. So the procedure is partial resection of middle turbinate and polypectomy. It's case number 8.
A teď se musí buď jako zkoušet, na kterou stranu je zahnuté, že buď to jako přivít.
Aha, jo,
I have to say that polypectomy is not fast. Polypectomy is procedure for 5 minutes, yes, but it is endonasal sinus surgery. It is completely different.
Aha, že jste to musel ohýbat. Rozumím. Aha, super, tak díky moc. So, tak my jsme připojeni?
Yes, we are here and we can...
připojení dolů?
Endoskopický pohled je jako hlavní. Yes, thank you.
Okay, so
yes, we can see.
Can we hear each other? Ještě můžete mě spojit teda?
Yes, we can hear it.
We can hear you.
Yes, great. So I can start talking. So this is endoscopy
Talking,
of
working.
So, can I speak?
Yes, you can, and work during
Okay,
that.
so can I have bandit suction? Zahnuté sání. So this is nasal cavity, left side. You can see inferior turbinate, and as we were talking yesterday, zahnuté, malé, it's very seldom that maxillary sinus is very affected. So you can see here maxillary ostium. You can see here corona and nasopharynx with Eustachian tube orifice. We can see nasal polyps, and everything is weak. So it's the first task will be just to remove all these polyps and try to find middle turbinate. I am personally not persuaded that this will be possible, because it was also very difficult to see it on a CT scan. Another thing is that we have here perforation of septum, so we are on the other side of the nasal cavity in the posterior superior part. So I will start with Blakesley, Chapáček. So this patient received prednisone, but unfortunately it was not helpful for her sense of smell. So 45. So she still has anosmia according to odorized markers test, and it means that we will do our best, but usually when prednisone is not working, also the surgery has limited impact on all functions. So, but we will try to just clean it. So in these cases we can use, or I prefer to use just Blakesley. We try to keep laterally to prevent damage of skull base. Hasani. So the first task is to find some anatomical markers. Again, the one we have is maxillary sinus. So what I usually use is this 45 Blakesley, but surely we have shaver. Můžeme shaver použít. So for a little while I will use shaver, but because I have no anatomical landmark, I will be very cautious about it. Nahoru ho točit. Aha. Tak já si to otočím. Okay, because we have a little bit different shavers, so we tried to find the proper way how to use it.
What kind of shaver do you use in your hospital?
We have a shaver from Storz, I think. Is that true? And this can be re-sterilized. What is quite nice when you use shaver in the posterior part of maxillary sinus, because using Blakesley you can tear off the mucosa from maxillary sinus, and in this case I will try to just leave the mucosa there.
You are more conservative with shaver.
Yeah. So, and even in this situation when I don't see real anatomical landmarks, so I will remove this one, Blakesley. A máme i větší, klidně může být. A ještě nechám si ho. So now I will look into the maxillary sinus. This can be for this part I can use shaver.
You can see it's navigating shaver, so you can see on the left, on the top, where the surgeon is.
So, and now I will use suction. So the next step is to see where is the landmark of the orbit, because the uncinate process I presume was resected. Again, this is maxillary sinus, but I do not plan to do much here. 45. Just I will only. No, this has to be ten štípák zpětný. Oh, this can be. So I will try to remove only soft tissue. So I'm not removing a bone from this anterior part. And now we will take Blakesley. Okay. And now I have the feeling with suction that there are ethmoids here. So. And we can go anteriorly till this part, which can be surely removed, these polyps. Máš větší, no, tak jo, větší. So I will take bigger instrument. So I still keep beneath the orbit. So if I go superiorly, I would be afraid of skull base. But in this, I can control it as well by instruments. Můžu to sání navigovaný. So if we have navigated section. So we should be aware always where we are. So we are in this situation, and as we can see, we are still far away from skull base. So these polyps can be removed freely, and even in this part, we are still far away from skull base. So I will remove it. We can use shaver, but as I said yesterday, I will take Blakesley. I prefer to do it with Blakesley. Ten velký? Tak ten velký. Ne, to je úplně jedno. Sometimes in this region, if you see a little bit different structure, it's of use to send it to histology, because it can be REAC, so respiratory epithelial adenomatoid hamartoma, which is considered to be tumor, but it behaves very benign. It's benign tumor. Zase 45. I still have no feeling whether there is a bone or not.
Honzo, are you okay with this kind of bleeding during revision surgery, or?
Yeah. This is still for me. the place I do surgery is quite nicely visible, so it's now it's okay. But if this worsened, I'm ready to use Surgiflo, because it was recommended here by nurses.
Tanya, for you, this kind of bleeding is normal in your department, or it's?
I think in a case like this, it is fairly normal because these patients, they have quite a bit of active inflammation, so you will get some bleeding definitely. Some people tend to give them steroids preoperatively to prevent this, but the literature says that it doesn't really help. And we don't want to give steroids to our patients as often as we did before, because we have to think about their steroid dose over the lifetime. So you can try to control things like hypotension that you want to have and the heart rate of your patient, as long as it's safe for the patient. But in cases like this, you will always get bleeding, and that's why it's nice to use a shaver in cases like this, because it sucks away the blood, you have clear vision, you have, it cuts precisely. So in cases like this, I quite like the shaver. In comparison to yesterday, for the inverted papilloma, I won't use it.
What's the blood pressure? Can you tell us? Can you ask anesthesiologist what the blood pressure is now? Can you tell us what blood pressure is now in patient? Jaký je tlak u pacienta, prosíme pěkně, krevní?
We will have a new blood pressure just now, so wait.
Okay, we wait.
But I don't think it's bleeding more than usually is usual situation. So I think this is still, I can see, as it was said, I can use FREER, but I am not sure that in this situation this will be that much helpful. And you see there are also polyps coming from the other side, so maybe we do some work also from the other side.
Yeah, I think the situation is pretty normal, at least for me being in a university hospital where the anesthetists start their training in the ENT department. Having said that, for the benefit of everybody attending, probably you should know what you want to ask for if you have somebody with especially revision sinus surgery. And that is normally a total intravenous anesthesia, so TIVA, which uses like propofol, which has the benefit that the thrombocyte aggregate activation is less diminished than if you use sevoflurane or some similar inhalative anesthetist. Then you want to have, you know, a controlled hypertension with a mean arterial pressure in its like 70s, but you know, obviously you have to pay attention to the comorbidities of the patient, so no need to do a wonderful face with the patient afterwards having some internal medical problems. Based on the literature where we did a controlled randomized trial and stuff like that, actually the heart rate has a significant impact on the quality of the surgical field, and that's at least in Münster, still unknown to most people on the other side of the brain-blood barrier. So if they use remifentanil as a relatively short-acting agent, giving them a lot of control in combination with the propofol, and sometimes they use a beta-blocking agent at the initiation of the narcotics intubation sedation, you'll get a better surgical condition. And that's something that has to be told to the anesthetist, because, you know, they just do what they always do. okay? And there is not a specific kind of examination where you have to go to the ENT before you're allowed to do, you know, narcotics in the ENT OR. So that's something were to be spread. And if you have a decent consultant in anesthesia in your department, then you can try to train him, and he might, you know, look at that you get better situation there. Or you go to private practice where you pay the anesthetist and make things easier as well.
Can the anesthesiologist tell us what kind of anesthesia he uses in this patient, please?
Only blood pressure is 100 to 55, so it's nice blood pressure. And what kind of anesthesia is we have inhalation anesthesia?
And remifentanil.
And remifentanil. So I think the bleeding is just appropriate to the situation we do here. The thing is that my intention is now to find the posterior part of ethmoids and sphenoid sinus, because this should be another anatomical landmarks, because I have no other landmarks here, so I'm not sure that I will be able to show you resection of middle turbinate. Můžeme zase tu, 45.
Yeah, it will be tricky if you can't find it.
Maybe we can now try again shaver.
Does anybody use warm water irrigation to stop the bleeding during the surgery? Recommended that it can helps you clear the view, the field, and stop the bleeding if you use 38 or 39 degree of Celsius warm water.
Okay,
do you use Exacil locally to the nose?
We like it. I like Exacil, tranexamic acid locally, but not in this situation.
Well, we have published regarding tranexamic acid, but we don't use it during surgery. It's only like after surgery or in selected patient where we have like thrombocyte aggregation problems, and you know the young person with immune deficiency type of, you know, everything going square, then we tend to go there because the topical treatment is an off-label use, so in theory we should tell the patient beforehand, and the intravenous use is still associated with the risk of thromboembolism, so quite a severe side effect, and you have to put that together, okay? Having said that, if you are like, well, I remember a case where we did metastasis of a nephrologic cancer, so not knowing that we're doing that. Anyway, and it was just like bleeding like hell, and that's a situation where we would use, everything, like shooting out of everything we have.
So now I reach sphenoid sinus, so this would be another anatomical landmark. So I will use section to work medially and inferiorly.
Honzo, I am sorry, I am not orientated. I came now, so we are on the left side or right side. Where are some structures for orientation?
So we are on the left side. I will suck out the blood, inferior turbinate, resected uncinate process. This is maxillary sinus, clearly visible. This is without, according to my opinion, we don't need to clean it more. And here I reached with the suction sphenoid sinus, which is clearly visible on navigation. So I will start to find out the skull base in maxillary sinus and continue anteriorly. So I can put out with shaver this tissue. So I will take shaver and I will try to reach skull base, because it will be another anatomical landmark for me here when there is almost nothing rest. So I have to be very slow and cautious here because we go laterally.
In these cases, like you can't identify middle turbinate, it's safer to go from posterior to the anterior part and follow the skull base and go laterally.
Yeah.
Say something to the bleeding. Say something to the bleeding during this operation, because when I was a dental student, I did a root filling, and this was bleeding and bleeding. And the professor, and I was suction. The professor come, what are you doing there? Stop suction. Suction produces bleeding. Stop suction. That was, and at once we filled up the root, and it was bleeding stopped. And this is what I do here. What I want to say, I will do here now some adrenaline-soaked tamponades in the nose, and I will go to the other side first. And if you put them cautiously out, not put it so, but very cautiously, we see in quite other situation afterwards. That's how operate these cases. We also published about tranexamic acid in the sinus surgery. We did it many years, but I can tell you there was no advantage for us afterwards. When I put at the end, I looked at this, there was no advantage. But don't do suction anymore. Suction produces a new bleeding. Put in adrenaline-soaked tamponades and go to the other side and then go back, and that's how I work. Don't stick to this problem here. We do multiple choice questions when I was a student, and when I cannot resolve this question, I go to the other question, and so I operate also here. And in the end, I succeed in getting my exam, and that's what I do here also.
We have now break, but the operation I think is continuing. So if you want to have a rest, you can go there, but we will continue.
Yeah. Tak vemem si 45. Sání. Jo, že můžem, aha. Podívejte, já furt mám pocit, že to je pro mě přehledný. Tady se dostaneme do etmoidu. A my jsme odpovědní, nebo můžu mluvit? 45. Aha.
Ale můžeš povídat, protože část těch lidí tady zůstává, takže můžeš komentovat.
Okay. So now I go to posterior ethmoids and clean up the ethmoids section. Okay. Asi si vemem už. So again, it should be visible on navigation that we are in posterior part of ethmoids. Now I will take 45. 45, plexy, furt ten velký. A vemu si zahnuté sání. Ne, ještě mě nech 45. So now I think we see just papyracea, lamina papyracea section zahnuté. So this can be removed, this part, and here I think I will take navigation again, and I will check whether we are still close to the orbit.
Can you perhaps just show us the choana just for like orientation purposes, which probably is a bit lower?
You mean for orientation? So here I will straight section.
Yeah, because
so
I think you are in the looking into the sphenoid sinus there, aren't you?
There is a sphenoid sinus. So
yeah.
this is the main point I use now for orientation. This is sphenoid sinus with its roof here. These are posterior ethmoids here. So I'm just now removing this part of ethmoids.
Perfect, thank you.
So it's and now we can see here that the mucosa is not normal, but close to normal. So I will use 45. No, 45 by X-ray. I always remove it very slowly. Oh yeah, so there will be skull base very close, so I vemu si rovný. So still we are not out of mucosa from sphenoid. So again, sphenoid is opened, and now we continue with this part. Rovný. Ještě rovné sání. Tlusté. A vemu si 45. Vemu si navigované sání zase. Now I will check whether I am on a skull base, but still few millimeters are missing. So if I go in this position, we are close to the skull base, so I have to be very careful. Now we are close to the orbit. Vemu si 45. A zase. Vemu si zase 45. A zveme jsou zahnuté. Vemu si ještě tohle. So now I think I see the skull base here. So we'll check it out. According to navigation, I'm still not on skull base, so but I can probably destroy this part. Vemu si rovnej. A zase sání a už zahnuté můžem. So now it's bleeding, but my experience is that when this is cleaned up, that the bleeding will stop. The only thing is that olfactory cleft. There is really huge polyposis, and I am not sure that I will be able to clean it in a safe way.
So you are agreeing with Jürgen Abrams, who said that, by reducing the inflammatory load and, getting the thick mucosa out, you'll get a better view, which is similar to, so the first is a mechanical thing to get out like the area of the nasopharynx, that you have a posterior drainage pathway, and I think it's Rainer Weber who invented the parallel sectioning of the nasopharynx as another means of controlling like a severe bleed, so more than you have, okay? And then you're right, so once you have the skull base and you can also control like the anterior ethmoidal artery, you then can safely resect the polyps medially to it. I don't know, have you checked the CT whether the anterior ethmoidal artery is below or on the level of the skull base in this patient?
We can look, it's very difficult to navigation. No, navigation. I think we are still far away from anterior ethmoid, but it should be if I check it, in this position, I'm almost superior to my suction. So we are just going close to the anterior ethmoid artery, which should be. There is only small like cell above it, but laterally. So I think it's almost on the skull base. I don't know if it's visible now on a CT, on navigation.
Yeah, the navigation picture is pretty small for us, but we will trust you. You probably have much better view. So I was just wanting to point out that you should be aware when you do sinus surgery whether or not it's...
I absolutely agree. So this is a place where I expect anterior ethmoid artery.
Yeah, go. Yeah, it looks like it's a millimeter or so below to us on the CTs. Thank you very much for the guys who are responsible for the technique. Thank you.
Shaver. So I will probably shave this part to have it nice. And as you can see, the bleeding is still here, but not that. Aha, musíme otřít. Jo, ještě. So there should be also, this is phenolpalatine artery, so we will, bipolar, we will coagulate it. Bipolar, so we will just coagulate this part, but this is just typical that here the bleeding comes.
Yeah, I think it's where you can actually expect it, and it's not a problem because you can easily coagulate it. And PJ Wormold actually says that your sphenoid sinus ostium is not big enough until you have this bleeding.
Yeah, there is still some pathology in sphenoid sinus, but I think this is quite nicely visible into it, and. To be honest, I'm not. My way is not to remove all mucosa. I am not the just. I don't like reboot surgery because I don't think that this. When I remove it, then the mucosa will be normal. The goal is to have intranasal steroids and to possibly work here. Especially in ethmoids. Ho můžeme? Jo, pedál mám. Můžeme pálit? Nepálí. So now this is... Okay, so but we can see that the bleeding is not that bad. We are waiting till it will work. Not yet. Žlutou nebo modrou? Modrou, že jo? Okay, we will suck it out. Tak můžeme. Aha. Yes. So great. So we have to clean the optic. Okay, so we will continue with cleaning ethmoids. Vemu si zase 45, ale menší. So I will take Blakesley, smaller one. So these are posterior cells which we are cleaning now. Great. Section, je to zahnuté. Now you can see that we have no troubles with bleeding. Musí zase 45. Ještě. Mám očistit. To musí sání zahnuté. OK. Vemu si navigaci, abych se kouknul, jak daleko je orbita. Jo, přesně. Ještě počkej tohleči. A navigovaný sání. So now I'm going to check where the orbit is. So I think this is the orbit, yes. It corresponds to CT scan and navigation. A ještě tady teda zase začneme s těma, ještě si mu 45.
Honzo, we will interrupt you and we try to continue with some presentation. We will follow you, and when there will be something interesting, we will go back to OP. Yeah?
Okay, great. I will continue to clean ethmoids until up to the frontal sinus ostium. So that's my plan. Zahnuté sání.
Thank you. Achim, can I ask you to have presentation, short presentation, please? Short, innovative topical treatment for sinusitis.
Yeah, thanks a lot. So the question was, what, in terms of innovative treatment, could we do after like sinus surgery or to treat sinusitis? And you already know my conflicts of interest. And I have a specific agenda because obviously we need to know that the rehabilitation starts actually within surgery, and there's a difference whether you have naked bone after your surgery or you preserve the basal membrane or you just have a superficial injury to the epithelium. And now, because sinus surgery tends to be from like balloon catheter type of thing, which is quite unusual in Germany, but quite often used in the US, to the reboot surgery, which has been advocated, for instance, by Klaus Bachert, where you strip up the mucosa. So just in contrast to what was just said in favor for the powered instrumentation for the shaver, you have quite a broad variety of situations that you may have. And the most important factors associated with improved wound healing, especially in the presence of Staph aureus, is interleukins. What is it doing? Interleukin 6 and 10, and we have done some studies regarding the effect of Staphylococcus aureus, and their toxin have an effect on actin, preventing the wound size to be like taken together, okay, to be diminished. So doing something against Staph aureus is also possibly a beneficial act. Now, with regard to the time frame, we have to teach our patient and also our colleagues that it's like the first 3 months that is especially interesting. So if you start doing something, you have different acts like getting rid of the crust and then reducing the edema, which may impose clinically as recurrent polyps, and then you have fibroblasts who are causing like scarring and restenosis. And then you have like the long-term result. And if you think about frontal sinus surgery, which is probably the most difficult one, we had a retrospective study in the Australian time where you are able to identify the people at risk to suffer from restenosis after 6 weeks. And the restenosis will then continue onwards until 1 year after surgery. And don't be mistaken, because the line goes up after like 2 years. The reason is just that you operate on some of these chaps, and then obviously the remaining ones are better. Okay, so it's a selection bias. However, so look after your patient, that you see them at least at like 6 weeks or 3 months later, that you see, okay, this chap is going into trouble and this one is behaving well. And then you have your standard therapy, which isn't standardized at all, but you do some kind of debridement, you do postoperative mometasone nasal spray most often, and you use irrigation to treat all these type of influencing factors, which I won't mention in detail. You have to adopt your treatment to what is happening there, and especially if you have done like extensive FES or extensive frontal sinus surgery, you want to do something more because the risk of recurrent disease is just higher. Now, one thing is starting during your surgery with thinking about postoperative, for instance, irrigation, and you have here like the size of the sinus, which is like about 5 millimeters, and the probability to reach this sinus afterwards using irrigation. And you may add, for instance, budesonide into the nasal douche, which is in German an off-label use. Nevertheless, it has been published quite a bit, and you have to teach the patient that they should use the irrigation in different positions to be able to, you know, affect like all the sinuses if possible. And there's even a meta-analysis with 360 patients around stating that the irrigation doesn't have negative effects and is beneficial with regard to reducing stenosis and improving quality of life. So, and then the next thing is there were people who said, well, steroids may delay wound healing. Should we start immediately or not? And as you can see by like the green edge of this publication, you can start straight away. And the benefit is that you have an increased compliance. So the patients start to use the nasal spray and they become aware, and that's a like kind of deal, psychological type of thing, of the end result. 50% is my responsibility because I'm the surgeon, and 50% is your responsibility because you have to use your medication, use your irrigation, stuff like that. So if there's a failure, it's not 100% my fault, okay? And this is like a psychological trick to get them being compliant. Now, we have had the discussion regarding packing, and I put it short, but just be aware that with resorbable packing, you can actually try to improve the situation with especially reducing adhesions. About 8 weeks, and adhesions may be a reason why the middle turbinate lateralizes and you get restenosis and recurrent disease or mucosis or whatever. However, you always have to look what is actually in your resorbable packing, as there are some with beneficial effects, and there are other ones where, like Metrodigel, you don't have a positive effect. And we just hinted at the fact that resorbable packing may be dislocate posteriorly, and if this happens during waking up, you can choke, okay? So also think about the negative effects also in resorbable packing, which is normally not as dramatic as non-resorbable packing. Now, there was a guy who started to take the resorbable packing and dip it into corticosteroids. And if you look here at the time frame, which is in hours, after like 5 hours, 70% of the prednisolone is out of the nasal packings if you analyze it, okay? So that's not a really long-term time of treatment. However, if you have a like drug-diluting system like we use in these two different studies, you can have, with a prolongated dexamethasone dilution, an effect even on the osteoneurogenesis after sinus surgery. Well, that's an animal study, and this precise stand is not available on the market. However, there is a drug-diluting system with mometasone available. I don't know whether it's available in Czechia, but most countries in Germany, and there's also an open registry going on. And they have proven in multiple studies to be effective, especially if you use them in the frontal sinus. There are different sizes and types available. This one is the contour-shaped propelled stand system, and I don't have any monetary arguments to have a personal benefit. However, in the US, they were showing that you have less outpatient visits, you decrease the indirect costs, and you have fewer repeat surgeries. So there is some kind of efficiency. However, it's only 375 milligram of mometasone included into such one stent system, and about 80% is diluted within 2 weeks. Okay, and now I've said before that 3 months is the time frame, so it would be nice to have something even longer than the 2 weeks. Nevertheless, it's something. The costs are about 750 euros, so you should look after whether it's covered by or not. There's a system in Germany to cover it if you make a special application. And now coming back to the reboot surgery, this is a nice diagram showing you where like all the mucosal lining is removed, completely removed. That's the idea of reboot surgery. And at least based on retrospective study, then you have like reduced recurrence. So that's another idea to be more aggressive. However, this will also result in a different shape of the airflow, and you may have more crusts. But it's important to improve topical, like irrigation, propel stents, whatever, and you shouldn't attribute then the crust to the stent, but possibly to your like type of surgery. We were included to use microcapsules and nanotechnology to include some kind of corticosteroid into a kind of matrix solution. And Yeah. First, to use it with both mometasone or dexamethasone, and the first trial was just to show that is effectively not delaying the wound healing, as it's shown here, for like 72 hours in an in vitro model. And then we used our standardized punch model, where you use a circular punch, giving you a defined wound area, and then you can use different approaches, including some antibiotics or natural plant-derived things, mitomycin, cold atmospheric plasma, which is a new technical development, or polyhexanide, which is a topical disinfectant, to see whether or not they delay wound healing. Well, and obviously I won't present every data on each of those because there are quite a few doctoral theses going on. Anyway, for polyhexanide, you're able to see that depending on your concentration you use, there are concentrations which are actually better, like the type bluish violet one control, which is this one. So if they are rapidly slowing down, like the red one, 0.5 microgram, that's actually an acceleration of epithelial wound healing, which is an easy feat to actually get it. If you mix hyaluronic acid with some kind of gelatin, I'm unfortunately not allowed to explain the exact formula because it's currently getting FDA approved. You are able to significantly improve interleukin 1 and also 6 to improve and accelerate wound healing again. So in principle, if you think of innovative postoperative topical wound healing, think about drug-releasing system, think about the stent system that have been developed, think about a way to apply your therapy, which may be as a part, adding it up to your irrigation and nasal douching for one thing, and think about different problems, including postoperative infection, where, for instance, doxycycline or roxithromycin have proven not to negatively affect wound healing, however, doxycycline being superior. And think about where you actually want to reach at, like the frontal sinus, to tell the patient about body position. And if you spend 700 grand on something, then make sure you don't pay it out of your own wallet. Thank you very much.
Thank you very much for this nice presentation. I saw some these special stands for the first time during Czech-German days last 2 years ago. Do you use in your practice these stands?
Yeah, yeah.
How often and what limits do you have?
We use it not at the maxillary or the sphenoid sinus, but only in the ethmoid and the frontal sinus. I'd say 90% frontal work, 10% ethmoid if it's like really small or problematic. And the company is advertising that by using it in the ethmoid, you could prevent lateralization of middle turbinates. We're having a look at that because actually I'm quite skeptic. I normally prefer to stitch the middle turbinate to the septum to have a really long-lasting effect. So that's one thing. The second thing is using the stands. You have the question, what type of frontal sinus work do we do, like DRAVE A, 2A, 2B, or 3 type of thing? And sometimes you realize it's just narrow, okay, and the contralateral side is completely healthy. And then you wonder whether going for a draft 3 will actually be a lot of surgery, a lot of time, a lot of, drilling, or whether the stand is going to be helpful. And if you have a diameter of at least 5 millimeters and the mucosa is, not too much, then we probably use the propelled stand, especially if it's a revision type of surgery. Okay.
Do you use it after operation when the healing is not quite well? So you are able to insert it not during operation, but in your office?
Principle, we are able to do that. However, you have to see the patient early enough to still be able to get there. okay? And that's a situation which we normally don't have, because our setting is that we look after the patient for like 2 weeks, and then in the frontal cases, I like to give them another appointment after like 6 weeks to 8 weeks, and most of the people will miss this appointment because they are traveling quite a few kilometers to get our place, and that's why the percentage of being able to actually attack in this situation is not good in our setting. However, in principle, it's possible, and we would like to get there. But you know, you need to have a regular schedule to get them up. I reckon that Jürgen and Nils are in a much better position because they'll look after their own patients, and yeah, that's a strategy. Last thing, just to give you another idea. When you do frontal sinus surgery, especially draft 3, you'll read about flaps and grafts. And that's not an easy feat in terms of surgery. And the second thing is that you want to fix the flaps and grafts in some certain place. And one is the frontal part of where you drilled, okay? And now, especially if you have like a free, well, I say graft, a free flap, whatever, yeah, then you can help to fix it also with such a propel stent.
How long do you use, how many years do you use these stents?
3 years, I reckon. But the number is like slightly increasing. The first were just, give it a trial, and now since the end of last year, we have some registry going on, which gives us the opportunity to do 4 per month in this type of thing. And yeah, numbers are currently going up, which is probably making Medtronic very happy.
Does anybody from Czech or Slovakia experience any experience with these types of stents? Nobody. Jürgen, and your private
I hope that you will ask me, Pavel. Wonderful that you ask me. So I don't use these things.
It is why I have to ask him, because our situation in university hospital is completely different.
Because Achim is
don't have to calculate.
He's a very rich man. He has university. They pay them everything. We don't use this. I don't. You
don't use it?
No, my patients don't rinse the nose because I'm against rinsing. I'm not convinced of this. I do this when the patients, after the operation, we put a plaster on the nose. So that's the biosystem of the nose recovers. We don't know oil, no stents, nothing. And I think I'm very convenient in my results. I don't see the opportunity or the need to take a stent or anything else. That's my opinion of all the patients. And I can tell you, we see all the patients again. All our patients, we see them again. 1 week, there's a strong system. 1 week, 3 weeks, 6 weeks after the operation. And so I want to give my money for other things.
There's also another aspect, which is the organization. Out of the INT clinics, okay, so having like beds in a ward, okay? We have 217 units with beds in Germany, and at the end of last year, 187 put forward this application to get a special refund for the 700 something, okay? And without this application and refund system, nobody, will use more than like 2 or 3 of those in a year, never. Because nobody can afford that, and we are actually not rich, but any money you want to give to my university is highly appreciated. Anyway, so that's a background story as well, and makes a difference whether I do it in private practice, where such an application is really time-consuming, and you need special people to look after that, and so, okay, and that doesn't help at all. However, as a large hospital, we get some declaration from the company, have to fill in some forms, send them to somebody, and they are negotiating this effect with the health insurance, okay? And for a university clinic, that's just 1 out of 100 or so, which makes it easier for us.
We participated our clinic, in a study of multi-center study with Germany. It was organized by Rainer Weber, and it was focused on closing of the nose after first operation with plaster. and I don't know how many days, 5 or 7 days, they closed their nose. 2 weeks. There was no washing, and the idea was that, for example, when you have Rendu-Osler disease and you breathe and the air is flowing through the nose, that it is very aggressive to the mucosa and bleeding can start. So if you close it, there is no blowing of the air, that it is much safer for healing and for everything. Unfortunately, we don't have results of this study, and I don't know if we can expect it. But it was a very interesting idea. So it is completely different to our approach generally when we recommend wash the nose. And how long do you close the nose? Can people sometimes to remove it?
2 weeks, and I said they could shorten it over 2 weeks, and then only in the evening and sitting in front of the TV, they put it there.
In the evening, can they sleep with open
Yeah, they
nose?
can, if they like it, after 2 weeks they can put it away, but I say and over the day, some hours you should use this plaster, and that's, was heißt durchsichtig? The plaster with... Transparent plaster, you cannot see this. And I open a little bit of the nose here, not no, so you can a little bit air can go to the nose.
It's not airtight. It's just diminishing.
I think our results are very good, and in former times we used oils and so on. You know this, but we don't need this anymore.
Yeah, with the oils we had a discussion as well, because there are some ingredients who are supposed from a pharmacist, he did a review, that they could cause lung inflammation if you aspirate stuff like that, which then skipped one of the major oils called a stop completely from the market. And there was actually nobody harmed. So he was demonstrating no harm at all. However, just because of the theoretical risk, they got rid of this oil, which is, wonderful demonstration of what harm can be done by significant research of clinical not significant findings.
The closing of the nose with a plaster is actually kind of what we learned from dermatology, because in dermatology we know that if we have a moist wound healing, it's faster. And basically the same thing should happen in the nose. And patient compliance is actually really good, because when people hear it, they always say, woo. But if you explain it to the patient that they don't have to get their nose cleaned because it's very uncomfortable for them. So they just put on the plaster for 2 weeks, no cleaning, no rinsing. They don't have this, like some of the patients, they have this very uncomfortable feeling of dryness after surgery and of fullness. They don't have it with a plaster, and it makes a huge difference, especially in cases where you have to remove a lot of mucosa, like in type 3 or in a reboot case, where every time you clean the nose and you take off the crusts, you take off some of the new mucosa as well. And you can prevent that. And you don't have this really bad crusting in a type 3, for example. And it's really nice and it's comfortable for the patient. And I would say that almost 100% of patients tolerate it really well if you explain to them what is actually why you do it.
Another special aspect is draft-free procedure. We do it relatively often in our department. And if we do the plaster on the nose, we don't have any problems with crusting. So we look there, and it stays open. Can you show many pictures if you want to see? I documented all this, and all our draft-free procedures are open at the end. And that's only by aftercare with plaster, suction, and this strong system. I tell you, 1 week later we see them, we clean the nose, 2 weeks later they come back, and 6 weeks later, and we see the patients then, I can see how it works. It works very well. Yeah.
Does anybody from Czech and Slovak Republic experience with this closing of the nose? Tomáš Pňák. No? Probably we have to be thinking about it. Any questions to this presentation? If not, so thank you. And I would like to ask Tanya for a short presentation.
So thank you very much. My next topic is going to be septal surgery with endoscope. I think all of you have been through this learning curve to do septoplasty, and all of you will know how hard it is to actually learn septoplasty because you basically can't see anything. Conventional septoplasty, as you will all know, was first described by Kilian, Freya and Kottel in the 1940s. And the endoscopic septoplasty has been described by Lanza, Sinnreich and Stamberger in the 1990s. The advantage of the endoscopic technique is that you have a direct visualization of pathology, especially in the posterior part of the nasal septum. Teaching, as I said, is usually quite challenging due to the limited view into the nose, but with the endoscopic technique, observers and teachers as well are able to see and follow all the different steps of the procedure. And if septoplasty is performed as part of sinus surgery, the endoscope is already set up, so why not use it? The instruments are basically the same that you use for your conventional septoplasty. In addition, you will need an endoscope, obviously. You can use either a 0-degree or 30-degree endoscope, and it's a big advantage to have one of these suction freers available, because when you suck inside this mucosal pouch that you create, it's nice. It's nicer to do your preparation. There are two different incisions that can be used to start off the endoscopic septoplasty, depending on the type of pathology that has to be corrected. The first is the traditional hemitransfixion incision, and you will use it if there's a dislocation of the caudal end of the septum that needs to be corrected. The typical incision that you would use for all other cases is the Kilian incision that starts just beyond the lower border of the apsilateral cartilage, which you can see here. And usually you will make your incision on the left side as a right-handed surgeon, so the left side of your patient, or on the concave side of the deviation. I now want to show you a short video of the procedure as has been done. You start your incision, this is a Kilian's incision, in the upper part of the nasal septum, and it goes down and it slightly curves towards the floor of the nose. Then, as you would do it in a normal case of a conventional septoplasty, you look for the right layer for your dissection, which is a perichondrial layer, and you can see how you can actually nicely see how the flaps are created. And the nice thing is you can see your pathology, like this little spur there, and you can follow your dissection with your endoscope. So even in the posterior part of the nasal septum, you have a really, really nice view what you're actually doing, and also in the superior part where it's sometimes hard to see what you're actually doing. So you continue the dissection till you end up at the posterior part, so that's where it curves towards the anterior wall of the sphenoid sinus. Then, as in conventional septoplasty, you do your vertical incision into the cartilage and your horizontal incision, and then you continue your dissection on the opposite side. Some authors, they recommend that you, at this stage, remove a strip of cartilage on the bottom of the septum to have better maneuverability of your instruments. And then you continue the dissection on the opposite side, same as you did on the left side, we do here on the right side. And also You do all this dissection up and down and to the far posterior part of your nasal septum. You can see another little spur there in the back. And then, as in traditional septoplasty, you can do the resection of the parts that are deviated. And you can still nicely see what you're doing. And also your junior doctors that might be with you in the surgery, they can actually see what you're doing, because that's the part that is hidden to you, to your observers when you do conventional septoplasty. And as you can see here, there's a little basal spur as well, and you can use a chisel to get rid of this. And you can also do your reconstruction. And then you fold back your flaps. And in most of my cases, I won't use splints. What I do is I do mattress sutures of the septum, because I think it gives you a nice equal pressure of the septal mucosa onto the septal cartilage. I use PDS with a straight needle for that. So it goes from one side to the next, and you move forward slowly along the cartilaginous part of the septum. And then with the last suture, you tie your flap to the intact mucosa of the nasal septum, and by that you close your incision and the procedure is done. So if we look at the literature comparing conventional and endoscopic septoplasty, there's actually no difference between the two techniques when we look at operating time, intraoperative bleeding, postoperative pain, and residual anterior septal deviation, as well as some of the questionnaires like the nose score, the SNOT 22, and the SF 36. The results regarding postoperative nasal obstruction vary between studies, partly depending on the time of follow-up, and the results are more equal with longer follow-up. There is a meta-analysis of randomized controlled trials that actually shows better relief in long and short-term follow-up with the endoscopic technique. But the literature shows better results for the endoscopic technique regarding the incidence of mucosal tearing, which is significantly lower with the endoscopic techniques, regarding the full relief of symptoms, which is also significantly higher in the endoscopic septoplasty. And when we look at postoperative endoscopic findings, we can see less epistaxis, hematoma, nasal crusting, residual posterior septal deviation and spurs, because you can see better in the depth of the septum, regarding septal perforation and also synechia. So I can only encourage you to start with endoscopic septoplasty, and I thank you for your attention.
Tanya, thank you very much for this presentation. I have one question. Is it surgery, this endoscopic septoplasty, is for one surgeon or for two people?
I use it as a one-surgeon technique.
One surgeon?
Yes.
Don't you have limits that you have to hold one endoscope in one hand and you can work only with the second hand?
No, not really. That's why it's so nice to use the suction frees or suction dissector, because then you don't need another hand for the suction. And when you're in the right plane of your mucosal dissection, then there shouldn't be a lot of bleeding. And usually when you've done your mucosal pouches, there's not really a lot of bleeding, so you don't really need a suction. And you have enough space actually to work in and do your resection and reconstruction.
It is your standard doing of septoplasty with this endoscope?
Not yet. I still do quite a bit of conventional septoplasties as well. But I do it more and more, especially in sinus cases. When the endoscope is already there, it's quick and easy, and it's really a big advantage for teaching.
For teaching, I understand. I agree. It is much better than without endoscope.
I mean, in the beginning, you will need a bit more time. because you're used to your conventional preparation and you know what you're doing, and you have to get used to the handling of the endoscope within the mucosal pouch and also the dissection. But I would say it's a quick learning curve.
How much more time did you needed when you started?
Maybe 10 minutes.
10 minutes. Oh, so it's not.
So no, it's not like half an hour or an hour more than it. It's actually just getting used to do this.
Victor, at your clinic, do you use endoscope as standard or exceptional surgery?
So we usually use the conventional septoplasty, but when we started with education of resident, we use the endoscope and we can check the situation on the screen and show some steps during this surgery. But we don't use, as you, for the whole procedure, the endoscope. So it was very nice video. Thank you so much.
Achim?
Question, how do you improve projection and protection in the nose via endoscopic septal surgery?
I actually have to say that in these complex cases, I use the conventional technique, but theoretically, you can do it as well. But the thing is, it is a bit more difficult because you have to angulate your endoscope in a different way. So for complex cases, I would probably, in most cases, still use the conventional septoplasty technique. But like in most patients where we do septoplasty in addition to sinus surgery, it's a high deviation that we want to correct or a spur somewhere, and for that I think the endoscopic technique is perfect.
Yeah, but you know, I think it's important that we state that for all patients getting kind of septoplasty, this is a subgroup which can be then easily taught, and especially if it's only like that, that's fine. However, if I need to go to the very anterior part, or you know, the question with the H-shaped like suture, you know, I've never tried it, but you know, I would also be hesitant to try to get, you know, ventrally after my incision and stuff. I mean,
definitely, it's not a technique for all septoplasty patients. Definitely not. Also, if you have to do like an extracorporeal septoplasty or something, I would still stick to the normal or the conventional septoplasty. Definitely.
Any questions? Peter, would you like to add anything? Nothing. So, Tanya, thank you very much. I would like to invite Dr. Chervenka. We can go back to the topic of yesterday when intubation was performed in child. So we will have a talk about congenital nasal lacrima, congenital lacrimal system obstruction.
Ladies and gentlemen, I am the ophthalmologist, and I would like to speak about congenital nasolacrimal duct obstruction. Lacrimal drainage system consists of lacrima puncta, lacrima canaliculi, upper and lower, lacrima sac, nasolacrimal duct, and it's going into the nasal cavity under the inferior turbinate. Lacrimal drainage system start in the 6th month of gestation as a solid lacrimal cord, and it in 16th week start its canalization, and it continues after birth. The most frequent place for incomplete canalization is nasolacrimal duct, and so I am going to speak about this problem. We know two types of nasolacrimal duct obstructions, simple and complex. The simple is the membrane in the end of the nasolacrimal duct between nasolacrimal duct and the nasal cavity, and has horizontal position, sometimes known as valve of Hassner. Complex incomplete type shows various different types of membranes between nasolacrimal duct and nasal cavity. in other positions as horizontal. Here we can see, for example, vertical angled parts. And complete time, it's bony obstruction. These types are when the nasolacrimal duct ends in the bony channel here or here. The mainly symptoms are mucopurulent discharge of the eye, epiphora, or combination of the tooth, and their incidence is about 6%. Treatment start conservatively. It's application of eye drops to the eye with lacrimal sac massage. Surgical treatment knows 3 procedures. It's probing of nasolacrimal duct, silicone tube intubation, and dacryocystostomy. Conservative treatment is recommended at least up to the 6th month of the age, because in this time there's the highest chance for spontaneously canalization of nasolacrimal duct. When it failed, probing is indicated. Probing is performed with Bowman probe. It can be under general or local anesthesia, and no more than 2 probings are recommended. Timing on first probing, if after unsuccessful conservative treatment, that's after the 6th month of age. Here we can see dilatation of lower and upper lacrima puncta. And Bowman probe is inserting into the inferior canaliculus, and here is changing the direction into the nasolacrimal duct, and here can perforate the obliteration. When conservative treatment and probings failed, a silicone tube intubation of nasolacrimal duct is indicated. This procedure is performed under general anesthesia, and sees insertion silicone tubes into the lacrimal pathways. We can perform bicanalicular intubation when the tubes are in both canaliculi, lower and upper, and here we can see typical silicone loop between both puncta, or monocanalicular when the tube is inserted in one canaliculus. It can be in lower or upper. Here is inserting probe of monocanalicular set. Endoscopic view, lateral wall inferior turbinate, and a special eye, and the top of probe is inserting into the eye, is removing from the nose. And probe is pulling silicone tube. In the end of tube is a special end, and now is this probe fixed in lower canaliculus. Silicone tubes are removed after 3 months in local anesthesia and in outpatients. Success rate of conservative treatment is about 85%, of first probing 85% and second 70%. Silicone intubation, monocanalicular or bicanalicular is about 90%, and dacryocystostomy about 90%. I have been, ladies and gentlemen, I have been collaborating with the Enten Clinic on lacrimal surgery since 1994, is 30 years. And I would like to say that I am very glad for this collaboration, and I am very glad for my being here. Thank you very much.
Stando, thank you very much for this nice presentation. The program of lacrimal system surgery is very important for our clinic, and I am very proud that we are able to cooperate with you for so long time. When we started, me personally, I did know nothing about these problems, and thanks to you, now the situation is completely different. You mentioned timing, when you have a small child, and you mentioned timing of probing, so of intervention, of any intervention. There are probably different opinions regarding this probing. Can you explain, can you say something to this problem?
Indication for acute probing in local anesthesia in outpatients are amniocele and acute acrocystitis. In simple type of nasolacrimal duct obstruction, the timing of first probing is how I was speaking about it after the 6th month of age.
Achim or Tanya, can I ask you, do you cooperate or do you do any surgery in collaboration with ophthalmologists?
In our hospital is a bit difficult, I would say, because we have one consultant who's definitely against endoscopic dacriocystorhinostomy and doesn't think that it's a proper treatment method. So he only does the external approaches and the torties.
Is your consultant or
no? An ophthalmology consultant. Yeah, regarding this, we only get there and the probing for the small children they do on their own, except if they can't find the probe in the nose, then we get called to please look for the probe. So the dacriocystorhinostomies that we get are usually from outside the hospital directly to us. In other things, we have a very good cooperation with the ophthalmology department, but yeah, with the lacrimal system surgery, it's a bit difficult.
It is, for me, it is good to hear different opinion than in Czech Republic, because I think that it is extreme in Czech Republic when we are speaking about dacriocystorhinostomy. We speak only about endonasal, because ophthalmologists they completely lose the ability to perform it, and ENT doctors mostly they are also not familiar with this surgery, and but it is not true, and it is not in other countries. It is done in some hospitals from external approach, also in Great Britain and so. But since 90s or last century, with advent of endonasal surgery, the number of endonasal dacriocystorhinostomies is growing up. What about Münster?
Yeah, the situation is similar. So we do have a very good cooperation regarding like orbit surgery and all different type of things. However, because apparently the number of ophthalmologic surgeons being experienced with the lacrimal pathway, the university tried to stick to the people they have to have at least one person. Now, because currently this consultant has left and retired, I'm looking forward towards the development, because if there is nobody around who knows where the orbit is behind the bulb, I won't tell that, there's a chance that, you know, the situation may change and become better for me. However, in principle, I would prefer to, you know, I'm quite envious and congratulate you on your collaboration. And obviously, with regards to the small canalicular, there are, you know, special techniques like endocanalicular laser therapy also, which are, you know, highly worthwhile and should be done, and you know, have their own problems, and that's nothing where I would, you know, start my work on. Having said that, you know, kind of clinic together would be my ideal, which is not going to end up because of the payment system.
Yeah.
And apparently in the German ophthalmology, it's like more retina type of surgery, or, you know, I don't know, the interior chamber, the posterior chamber. That's where, you know, they get their habilitation and money and whatever. So they're not strictly interested into lids and lacrimal pathway.
It is important to find, I think that for this surgery, and doesn't matter if it is from external, endonasal, and other approaches, is to find somebody on at ophthalmology department who would like to cooperate. It is the most important. And it's like, for example, thyroid surgery. In Czech Republic now, it is done more and more frequently at ENT departments, plus general surgery. In Germany, mostly general surgery, still, I think, departments, and it depends who is on the other side.
Well,
yes?
Well, now Jürgen has just left. He has made a famous case in court in favor of us doing thyroid surgery, and the German Society of ENT, so the scientific community, is supporting the fact that ENT is going towards thyroid surgery. Having said that, if you are trying to apply for boss position at some, you know, it's not the first thing that you tell them that you're going to do thyroid surgery, otherwise the general surgeon will kick you out. Okay, out of the program. So there is some political component. However, the Germans want to take over or, you know, look after it as well.
So back to lacrimal system surgery. Do you have any questions? If not, so stand up. Thank you very much.
Yes, I would like to say one sentence. It's very good. It's necessary to concentrate that problem. He diagnosed more than 15,000 of people with lacrimal drainage system problems. From that, more than 10,000 children. From these cases are a lot of cases indicated for operation.
Most of ophthalmologists, they can concentrate cataract surgery. Yeah. It is much better. Thank you. Vicky, briefly try to introduce the case.
Yeah, rapidly. Case number 6, the adult woman with mycotic sphenoiditis with problems like a transient severe headache from 2021, and there was an MRI with opacification on the right sphenoid sinus. After antibiotics, it was affected on headache, but the findings on MRI were persistent. So this is a clinical findings with prolonged secretion from the right sphenoidectomy traces. And on CT opacification of the right sphenoid sinus. So the procedure will be endoscopic sphenoidotomy. And operating theater number 7, I think.
Honzo? Vicky, thank you.
Thank you.
Honzo?
Forensic theater.
Yes, so we are here and you can explain what was done or what would you like to do.
Okay. The patient suffers from headache and the CT scan shows full of the right sphenoid.
Dr. Hanak.
I am going... Do you hear me?
Yes. I only forgot to introduce you. So, Dr. Hanak from Brno.
Okay. Okay, the patient suffers from headache and the CT scan shows that right sphenoid sinus is full. I'm going to do the right sphenoidotomy. We can start with rhinoendoscopy in the right side. Okay, here. We can show that there is some spur on the nasal septum, and I will have to do the resection of the spur. Give me, jo, dejte mi chapáček, já to ještě vytáhnu tam ještě, protože, tak. I cut the mucus before. And okay. Tak, dejte mi toho kotleho. Zkusíme takhle na to. Now, I would like to remove it because I need better view. Tak zkusíme to dátko, a to je kostěné. I use the chisel for removing of this bone spar. Tuk tuk. Tuk tuk. Tuk tuk. Good. Tuk,
International tuk tuk. How do you say it in?
Yeah,
tok tok. Tok tok. Tok tok.
No. Okay, again. Chisel again. Yeah. Good. Stop. Forceps. Tak. Okay. And we can continue. We should find the primary osteum in the ethmoidal recess, and it's about 7 centimeters behind the anterior nasal spine and 1 centimeter above the roof of the choana. There is the roof of the choana. Yeah. And give me, freer. Yeah.
You said 7 centimeters from, not from the tip of the nose.
No.
Not from anterior.
Anterior.
Spine. Yes.
Yeah. There is middle turbinate and suction.
There is some swelling in the sphenoethmoidal recess.
Yes. This one is superior turbinate, but the superior turbinate is swollen. Můžeme tam dát ještě anemizaci trošku. I must use. Sorry. Počkej. Je toto. Tak, dobrý. And again. Project strips. I think the nasal septum is just a bit deviation the right side. Yeah. Freer. That's clear. Okay. I can show the left nasal cavity forceps nebo chapaček. Tady jsme dali. Okay. The mucus looks healthy. Yeah. Inferior turbinate, middle turbinate, middle meatus, yeah. Freer. And in the left sphenoid sinus is small, probably polyp, yeah. But I don't want to open the left sphenoid sinus. Okay.
I think there is a small hole in the intersphenoidal septum, and maybe if it's something like mucocele, so it can expand to the left sphenoid from the right sphenoid. So we will see. So plan A is open only the right side. Yes, Honza?
Yeah.
Okay.
Yeah, I agree with you. And it's very narrow.
Sometimes if I look on CT scans, I'm happy that the nose will be perfect for this kind of surgery, and I am surprised that it isn't. Do you have the same cases?
Yeah, of course.
Definitely. I'm still a bit, not scared, but I still have a lot of respect for sphenoid sinus surgery. Because it's in some, or in a lot of cases, it is quite challenging to get there. I know there's different ways of getting there depending on how wide or if you have to do ethmoid surgery and how wide your ethmoid is. But all of them, they have challenges, I would say. So I have quite a bit of respect still. And in a lot of cases, you see that it's quite narrow and you can't perfectly get there, I think.
Obrovský teda. No, dobrý, tak.
Well, I think for the sphenoid, in principle, you have to be aware that there are possibly 4 different approaches. So one is the side you want to tackle, the second is the other side, the third one is that you can go transethmoidal, and the last one being the fact that you can go via like septoplasty, so like the neurosurgeon go. So and each of those 4 approaches may have its like moment, because in cases of extreme asymmetry, when you have a very small sphenoid, or you have like the other case with this skull-based dehiscence with the metastasis and bleeding type of stuff, I mean, afterwards everybody is, no, it's just a question of planning. Then you are aware if you can't get there, you have another tool to play around with, okay? And that's why I think it is very sensible that he looked at the other side as well, in this case, to just get an impression what is easy, what is not easy, stuff like that.
Okay. I pushed the medial turbinate laterally, and now I try to
Can we have a picture of navigation?
Nemůžeme, že? Jsme nechceli.
No.
I think I can't use the CT navigation because the patient didn't prepare for this. Yeah.
So you don't use navigation for this procedure? And in your department, you usually don't use navigation?
I use CT navigation if the patient will undergo a revision phase, or I remove the tumor from the for example skull base. Yeah. Tak zkusíme ještě toto. Dobře.
Because I think that recommendation is for posterior ethmoids, for frontal sinus, from revision surgery, for tumor surgery, and for sphenoid, if I don't
Dobrý, já jsem teda frýra, protože tím se nic tam blbě dostávám, já se to musím to tam. Dobrý. OK. A to zkusím prostě tady se tam dostat nějak. OK. Takže to je přes tu. To asi nebude tak jednoduché.
If it will be bleeding, you can use Surgiflo.
I know. Už tam jsem asi. Psaní. No, tyjo, tak to je... Nebude tak jednoduché. I try to palpate. Totiž to je tady more. Freer up, freer.
So again, above 1, 2, 3, the suction diameter, and then through the anterior wall.
Usually there's different ways of finding the natural ostium, and the one is from the choana. And what helped me personally quite a bit is not to look for the choana, but for the superior turbinate, and use the lower rim of the superior turbinate to guide you towards the natural ostium. Because when I still used the choana, I was always too deep, and that's where the bone is quite thick. And when I started using the superior turbinate, it made things for me personally a lot better.
But I think that the most performed beginner mistake is that they go more up than they should. Yeah, I think so. Better is a little bit down, but definitely there is a thicker bone, so there is more problematic to achieve the sphenoid.
But if you take the lower border of the superior turbinate, you can't get too high either. So if you stick at that level or slightly below, you're still safe.
Can we see the superior turbinate? Because I haven't seen.
There is only swollen. I don't know if this. I didn't see superior turbinate. Not study. Okay. Dejte mi dolů, Carison. Nebo počkejte, ještě.
Now, Honzo Hanak, now we can go back to the opposite operating theater. So we will follow you, but we return in a few minutes, yes? So, Honza Vodička.
I hear you.
Where you are, we followed you, but we don't know where we are. What side?
Now we hope we are almost finished, because there are places I'm afraid of, meaning cribriform plate especially. So this is left side again. You see that bleeding stopped almost totally. So this is this is maxillary sinus. Even if there is some mucosal swelling, I'm not going to remove it. I don't think it's that helpful in this case. And we have blood here as well, but you can see that the mucosa is quite okay. So then we have here sphenoid sinus. These are ethmoids. This here is lamina papyracea. Here there is a small dehiscence, so if the nurse, můžeš zatlačit na oko? If nurse press the eyeball, then you can see it's moving.
Yes,
so
we can see.
This is the orbit. And here we can have frontal sinus, and I am, as it was said several times here, I'm not going to touch it too much, just only like broaden it. So this is frontal sinus. I will remove this small parts. Okay, I'll take. Unfortunately, there is nothing almost which left after what could be just named as middle turbinate. So we don't see middle turbinate. We see here huge perforation, and here we see some like tissue, swollen tissue with polypoids, and I'm not going to touch this part. Anyway, we are here very close. If I look at the navigation, we are here beneath, immediately beneath cribriform plate. So when we go to the other side, I was probably more conservative, but again, I'm a little bit afraid to touch this region. So again, this is huge perforation, but straight section. Here we can see nasal cavity, corona. Here we can look into the maxillary sinus, and you can see there is nothing that bad, or mucosa is only swollen. This is sphenoid sinus. I have to remove this mucosal layer. This is okay. So So here this is sphenoid sinus. We can see sphenoid sinuses on both sides because we have perforation which was maybe created by previous surgery or by the destructive process of polypoids. I do not know, but this is huge perforation, and we see both sphenoid sinuses. Here this is ethmoid. I will take a curved suction. And now when we follow the skull base, we can go anteriorly. There is still small mucosa which has to be removed, so I will do it later on. And this is again frontal sinus. I can see it also on navigation, and again I won't touch it too much. So this is frontal sinus here, again without nasal polyps. So I am almost at the end. I will put there a Gelaspon with Exacil. And it is recommended to not only saline irrigation, but also to spray local steroids in the nasal cavity almost as soon as possible, because then the polyposis will come or recur again. Generally, I am not really sure that I will help patient with olfaction. We did our best, so we will see. But there were some negative points, like she didn't react to steroids. She had no sense of smell after steroids when we measured it by with using odorized markers test. So the main goal is not to damage or not to cause some trouble to the patient. Hopefully she will be able to breathe through her nose, but the main goal to improve her olfaction, I am not really sure that we will be successful. So this is only my short comment to this patient. I think she's a candidate for biological treatment anyway. So probably that's it.
Hanzo, thank you very much. The question of Peter was if there anywhere is there anywhere anterior and posterior ethmoid artery on left side?
Good question. So I think here, if I have navigation, but it doesn't move here. If we move here, then here beneath, above, I have anterior artery. It's visible on CT scan or navigation. Here now.
Yeah, and I think it's a typical situation. You have a frontal sinus, and then you have one cell, and then you have a line which comes from like posterior to ventrally, one cell septum. And I think on the other patient side, it's actually even easily or better seen, because you did such a nice preparation there, where you can also point out the anterior ethmoidal artery. And so while we are all hesitant to injure it, it's also helpful if you have the frontal sinus, then you have this rule of thumb with one cell, and then you can get there and see it. And once you know it, you know where to stop getting the mucosa tearing off. Or you use a bipolar first, perhaps.
So this is this one cell the mucosa can be removed from here, but this is a place I have to be very careful because of ethmoid artery. Ještě si vemu 45.
We discussed there also some points from lecture of Achim Boyle, and it was about new trends in local treatment of endonasal diseases or chronic rhinosinusitis after surgery. And my question for Achim is it the indication for this stents?
Yeah.
The clinic?
I mean, we see that within the frontal there's some thick mucosa left, and we have the decision to make whether we open it up more, so being more aggressive, which would one strategy, and the other strategy would, for me, to put a stent like in. Okay. Personally, because you know, I don't know how thick this instrument now is, but I reckon we are at an opening of about 5 millimeters, could be more. I would probably more opt towards opening up more aggressively because there is inflammation. However, yeah, if I can't do because of anatomic reason, that would be a patient for getting a stent.
Here has experience with these stents. Can you explain us how to insert it? How does it look when it is not in place?
Yeah, you get a package with an application device and the stent. And the stent is made from two parts. The one is like the mometasone being sprayed on a type of network. Okay, the network is like well, a plastic-looking type of whitish something. And you can take this network and put it together and load it into our application device. The application device being something similar to a suction device, just with, you know, plastic and slightly bendable.
What is diameter of this approximately? Of
4 millimeters, 3.5, something like that. So, and you have an, you know, the cannons in like Middle Age where they put their cannonball in and then they use the stump to put it really bad. So you have a stump like that to make sure that it's properly inserted into your device. Then you take your endoscope. You have this application device having a syringe type of stump at the very end. You put your device up there, press, and it will, you know, go out of the application device into the sinus. Okay? You pull back your application device, and then using a Blake, you can still, you know, do minor changes so that you get a nice mucosa coverage. Now, in case you are completely unhappy what has happened there, the stand is still has enough strength in its material that you can pull it out, reload, and do it another time. Okay, so it's not only once, and if it doesn't work, it doesn't work. Okay. So,
and it is necessary later to remove it, or
no,
not?
It's completely resolvable. 80% of the mometasone in the stand is gone within 2 weeks. And you are allowed, and it's possible to remove the stent parts because they degrade, they break like little stitches or something, and you tell the patient if anything whitish comes out, don't bother, okay, don't be afraid. And you can use the suction to get it out, but there's no need to do so. And that's one of the abuses. If you have a patient with dementia or KIT or anything, where you don't want to touch the nose ever again, in an ideal world, you can put it in and forget about it.
In past, in Czech Republic, were used different types of diameters of silicone stents for frontal sinus. Do you use it anymore, or it is something what is over?
Just silicone is something we really, really rarely use. Really, really rarely. And now, perhaps, so the application device has a diameter of like 5 millimeters. But if you pull out the stent, it will open up even larger, okay? It expands. So the diameter of the stent is not 5 millimeters, but depending on anatomy, more. Now, silicone sheets is rarely used. I don't know, Tanya, do you? Tanya doesn't use.
We used it for type 3 years ago, but not anymore for anything.
Thank you.
In type 3, because the one thing that we use, and that's going back to what Rainer Weber says, and so we are putting really laxate silicone sheets in the nose, but just to get a moist feeling in there and to prevent anybody to suck at the skull base and, you know, wherever. Okay, just leave it alone. So it's more prevention of iatrogenic failure rather than, you know, a treatment for the patient.
What are you doing now, Honza?
I just... Který Honza? Which one?
Which one? You one.
You one. Okay, I just try to make mucosa like smooth and without any... Even if this is terrible, I just was again thinking about this part, but I will leave it on the left side. And on the on the right side and on the left side, it's cleaned up quite totally. There is one thing about olfaction. If we have olfaction only one side, then this will just enable us to breathe, and people are not able to realize that the other side is just without olfaction. And in this case, when we have septal perforation, it doesn't play any role. So maybe you can see that on the right side of the nasal cavity, there is more remnants of swollen mucosa. This is this one, but I am not going to just remove it, because I'm first of all afraid of liquoria, and second one, I don't think this will help in olfactory function, so there is no reason to do it. And as I said before, the main goal is not to just somehow damage or cause some troubles to the patient.
What material are you inserting there now?
It's Gelaspon with Exacil. So this is okay. This will end up in the other. It doesn't matter. I will use a lot of it now because it's huge. Jo. Tak ještě Exacil klidně. A ještě Gelaspon. So we will pack it all with Gelaspon. And if you see now, there is almost no bleeding. So if we remove all mucosa, which was just inflammatory mucosa, then the bleeding almost disappeared. But anyway, as far as I have information, we had at least 300 or 400 millimeters of blood loss. 300. Okay.
And what was blood pressure during operation?
I think it was about 100 to 60. So it was perfect. So the cooperation with anesthesiologists was perfect, and to be honest, this kind of revision surgery, even if patient is prepared by prednisone and so on, is very difficult. So I think it's really nowadays a question about proper biological treatment for these patients.
A question, because you have this huge septal perforation. Do you have any hypothesis of why she has this septal perforation? Is it like consequence of the bulk of the polyps, or do you suspect some other illness for her, or is it like iatrogenic, or what do you think?
I think two are main. So one is the destructive process of polyposis, but I think there is also some part of iatrogenic. Probably if you remove mucosa and enable polyps to make pressure on it, probably this was the cause. But on the other hand, I don't think that with this perforation the patient will have trouble. So hopefully for her it won't be that just or trouble for her.
So Honza, thank you very much
You're welcome
for this nice surgery. we can go back to opposite OR. Now who is speaking now? Yeah.
Hi. Sorry that I didn't comment before, but because I am a typical man and I can't do two things together. But there is very narrow nasal cavity with just a bit deviation of the nasal septum in the right side, and now I opened the sphenoid sinus inferiorly and medially, and you can see that there is probably mycetoma. Jo, můžeme. Těžký se dostávat.
You are tired.
No, sání. Yeah, there is middle. There is.
Can you show me where was the spare you had resected? What level for orientation?
Here. Sání? Tady. I think here, yeah.
Yeah. And you are above this? Yeah.
I had to do because...
What is the distance between this opening of the superior aspect of corona? How many millimeters or centimeters?
You mean
yes, the distance from superior aspect of corona. What is for us landmark?
I don't know if I think 3-4 millimeters or 5 more, maybe 1 centimeter. Because there is roof of the corona.
Yeah.
There was the spur. Yeah. There is. Sorry. There is the superior turbinate, yeah?
Yeah.
Sání. Jo, já si vytáhnu kus toho aspergillomu, aby jsme měli ten vzorky. Ještě ten Kerison nahoru. Jo. A to tady ještě rozšířím. Ale něco v tom je, jenom kousíček kosti. To je kolika? To je 2 nebo 1? 2. Ještě mi to vzali. Jo. I always open the sphenoid sinus inferiorly and medially, and then I do the superior part and laterally, because I want to protect the lateral wall of the sphenoid sinus.
Hansa, I don't know. It's Akim here. Sorry. As the section is probably around like 4 to 5 millimeters. Personally, I think that the opening size is quite good. Now my question is, have you tried to like irrigate this mucus which is on the lateral wall, because everybody of us is hesitant to go there at all, and perhaps by this you could like get rid of quite a bit of that fungus as well?
Yes, I can do it. Tak můžeme vypáchnout. Chlapáček.
And now, after my suggestion, the next challenge, do you send that for like microbiology, or do you also, for histology or the tissue in a way for microbiology. Because like our microbiologists, they love to get tissue because they state that sometimes it's easier to get, you know, any results. Otherwise, especially in fungus, we have like a negative culture type of result, so not helping at all. I don't know how it is, you know, for you guys here. Some are dipping ahead, some are sleeping.
We sent Remicetoma for microbiology and PCR examination and PCR in our clinic in Sant University Hospital, Brno. Yeah, and for histopathology.
Well, I actually have to say that in Freiburg we had a discussion with our microbiologists because in most of the cases it won't have any consequence because it's just a fungus ball and no invasive fungus sinusitis. So we actually agreed with them that if it's a typical fungus ball and the patient is not immunocompromised, we don't send in anything anymore because it doesn't have any consequence except for giving them some work.
Well, the question, because there are quite a good studies around that fungus is airborne, and even neonates have fungus in their, well, at least nose, if not sinuses, and that was when Punikau invented amphotericin B as a possible treatment. That was one of the lines of argument against that. So personally, I think that if you don't get a result, that's fine. However, as being a university, I ask myself whether this lady or why this lady has this kind of disease and not another one. And in a world we are tending towards like structured data acquisition, and so obviously if I'm you know having to look at just money, so now Jürgen is right for me having lots of money, but then I tend to send around specimens to get them into a biobank. That's what we pull up together with the tissue, and to see whether any kind of local reaction is the reason why it is opening up or developing this kind of disease. But yeah, that's research and just looking for further PhD to be done.
And the other thing is that some people get nervous when they see some kind of fungus on the microbiology result, and they think, oh, we have to get antifungal therapy because there's aspergillus or whatever. And that's also a little part of why I don't want it for every patient, because then someone starts some antifungal systemic treatment and destroys the liver of the patient for nothing. So, yeah.
If I can, Peter from the operating room, do you think that it's a mycotic fungus ball here? Because I don't think, or I am not sure, because it can be chronic sphenoiditis with like dryness of the pus inside. Sometimes if we have this kind, we send it to the bacteriology, to microbiology, to pathology, and they don't find their mycotic hyphae or aspergillus or fungus ball, only like pus. What do you think about that? Do you think that it is a mycotic fungus ball here in this case?
It could be. I'm not 100% sure. I had these results as well where I thought I'm 100% sure that it's fungus, and it came back negative. But I would still try to remove it completely, so that there's nothing left. And then the patient, if it's fungus ball, patient is cured. If it's mucus, it's good too.
It's only academic question because it doesn't change any treatment after the surgery. Yeah?
But Petro, didn't we have like double densities in the CT scan beforehand? In this case?
That not visible like bony opacification there, only on soft tissue scan, cerebral scan. There is a little bit different opacities there. So only our our radiologist told us that it can be, but we are not sure about that, about mycotic sinusitis. But it's definitely only academic question in this type, because it has to be removal all these pathology. Yeah, do you agree? But here it seems like mycotic, yeah? This one.
Yeah, I agree.
Yeah, but it's not, yeah. So maybe I am changing my opinion.
I think because the fungus makes it, more concrete, so less fluid going over viscous to then calcium including in there, and this giving you double densities. I think there has to be a process which makes a difference towards like bacteria or viral type of thing. And thinking about, why we develop acute or recurrent acute or even chronic with or without polyps, we still need to understand much more regarding the pathophysiology. And now, yesterday you gave, tremendous amount of impact, what you know about like biomarkers for inverted papilloma and stuff like that. And Tanya said that inflammation may lead to inverted papilloma. And it all comes back to like basic research to understand what the mucosa is doing and why it is doing, and whether it is doing it in an anaerobic or aerobic atmosphere. So, and that's why I would love personally to have like a huge biobank with tissue and blood and, bacterially and fungal specimen next to each other with data on like comorbidities and age and gender and whatever, and that in like 20,000 patients, and then we can start to do a decent multifactorial regression analysis to find out what's going actually on there and which interleukin is working there. But this, like the type of specimen you're getting now, is looking typical for fungus, and it also explains why it's quite difficult to irrigate it out of because it's attaching to the mucosa in a way, okay? Whereas the pus would be easily removed in a comparison.
It's a small part of the mycetoma.
Yeah. It's surgery. There is in other sinuses too. If it is visible, it doesn't mention that you can reach it and you can remove it. And in this sphenoid sinus, which is most posterior part, it's the most difficult, I think. And because of what is behind, yeah, definitely.
Have you used the tilted suction in there? So you use normally for maxillary type of thing? Yeah. And the other one, yesterday they gave me this grabbing instrument, which is for the frontal one, which is not like 70, but about, I don't know, 40 to 50% angled. Because I think it's more about the angle position. Yeah, exactly.
Yeah.
And you can't put it up. So superior, if it's possible. Yeah.
I think. Watch. Sani.
So I think it's almost clear.
Yeah, I think so.
If you look into the sphenoid, usually if you have open only one sphenoid and the second not, there is a big problem to identify anatomy there. Only after you open both and you resect the septum, you usually can see the nicely sella, tuberculum, carotid, and everything. Yeah? Now we are rotating the endoscope. If we can rinse it a little bit more.
But Petr, I think he has, in a way, slightly opened up the contralateral side as well, because ventrally, medially, there is something looking like a cell, and I thought that perhaps because it's at the area of the septum, that's actually also starting point for the, And you know, I don't know if you can get in there with a like bended instrument or something where the mucosa still is, but it's just a hypothesis.
Yes, probably. Sondu.
And the defect, it's a slapper, no? There's nothing there. The defect was a little bit posteriorly, no? On the septum, I think.
It was. It was superiorly and posteriorly. I just thought because you got rid of that spur, perhaps in this area you could have opened up the ventral part of the sphenoid sinus, but as you have shown us, it's something,
I think it's on. It's like mucosa, only stripped a little bit, and there is the bone, or it's a. Oh, no. It's a left sphenoid, or it's a.
No.
What's that?
You wouldn't have, by happenstance, of navigation.
No. We don't have navigation. Can you look into the CT scans?
I think.
What is that? Because I don't know. I
think.
Don't remember that it's something like that. Definitely navigation will be beneficial here.
Peter, and is it necessary to know it exactly? For patient, what benefit does patient have?
No. It's not necessary, I think, but I'm curious. What is it? You are not? You are not.
So, Achim, how they should widen this operation?
Okay.
I think they did an excellent job. They got rid of the mucus, they treated the pathology, and now it's only the curiosity which I join with Petra to know whether or not the other side has been opened up. If yes, and I would presume that that is like the beginning, then there's no harm done instead because the mucosa is thickened. It may help that even the contralateral side can start.
I think it can be some pneumatization of the rostrum sphenoidale, but I don't remember that it is there.
Sáni?
Co to je tady?
Co tam dělají?
Co tam
Tady je
kostičky.
Yeah. We haven't had the CT scans here, so we currently can't help you guys.
Yes. There is a subseptation of the rostrum sphenoidale in the ventral part. I have seen CT scans now, so it's like this right sphenoid is subseptated into two. Yeah, do you agree with me on the CT scans? Can you see it?
Give us a second. We are currently working on getting the CT scans working, I reckon, I presume.
Okay. So we can look afterwards. So I think that I will be happy with that. What about you, Honza?
I finished.
With the surgery?
Yeah.
So Surgiflo jsme použili?
Surgiflo, I didn't use for Surgiflo.
Okay, so and we will use Surgiflo now for stop the bleeding.
Okay.
Surgiflo máte nachystané?
It is no standard in Ostrava, but we would like to
but there's a study coming from Ostrava. Use Surgiflo in every patient.
No.
During neurosurgical procedures, even in pituitary gland surgery, they have one or two
can you,
Surgiflo.
Peter, sorry. Can we see nurses preparing this Surgiflo? Stop.
Zevní pohled, prosím.
Zevní pohled na sestřičku zblízka.
Já nevím, jestli ji vidíte.
Vidíme, ale blíže, ať to přiblíží pomalu, ať pracuje pomalu.
Fokus. Jo, to já s ním hýbu, víš, já nejsem úplně
ať ne, ta sestřička moc, nedělejte to.
Sestřičko.
Nedělejte to. Stop it.
Zavolejte prosím nějakého technika odvedle.
Nedělejte to.
Stop.
Jste šikovná.
A můžete to dát do originálního balení, ať to všecko vidíme, jo. Jak to vypadá.
Na kameru technika, prosím pěkně. Wait a second, please. We are looking for technician. Cameraman. Můžeme, prosím, fokus na sestřičku, na její ruce?
Ať pracuje pomalu.
Pomalinku pracuje. Ona to dává zpátky, sestřička. Ona je... Ne, my musíme všichni rychle tady pracovat, protože... So now it's like in original pack. And you can start with preparation. So we call it, nurse, we need Surgiflo. The patient is bleeding.
Menší zvětšení, prosím vás, ať nám to sestřička neukazuje tak, ale klade to pouze na desku.
No, to kamera musí.
All things are in original box.
There is some liquid now, and nurse put it into the lahvička, small bottle. She mixed it up and put it into the syringe now. And now she put it into this miska. Bowl. So another syringe, she put it into the syringe now and remove the air from that. Removes. Oh. And now she connects these two syringes and she mixed it. How many times? 6 times.
6 times.
And it makes like foam. Vlhké ty neuropaties. Vatičky. Vatičku. Rychle, šup, jak na neuru. It's a special
this plastic tip is flexible, Petr?
Yes.
Can you show it? Can you show it how flexible?
You can, jak je to, ukažte, tak, it's flexible, so you can curve it, bend it if you want, at the end, how you want, okay? The straight, it's perfect for that, okay? And we can
change the
apply the Surgiflo.
Okay.
So it's like thrombid foam. Touch. Yeah. And you can see it fulfill. Enough. And over that you should put neuropathies and wait for 2 minutes.
2 minutes.
You can press with neuropathies the bleeding side. Tak, you wait. Můžeš dát tady třeba trošku Surgifla teďka na tu krvácející tohle a pak to budeme vyplachovat, jo? We put it into the nose. Sometimes if it's a rest of Surgiflo and the neurosurgeon doesn't use it during the surgery, then we put it into the nose and it's like stop a bleeder in the nose, so it's not necessary to perform packing there afterwards.
nevím.
Aha.
Dobře, ještě tady pak pláchnem.
Aha. A zase vatičku.
A vatičku tam můžeme dát.
So it's perfect, for example, for bleeding from cavernous sinus, which was before Surgiflo or before Flowsil. It was the end of the pituitary surgery if you traumatize cavernous sinus. And now you put there the Surgiflo, wait for 2 minutes, and then you rinse it with water or saline, and you can continue with surgery. I think it can be used in, for example, autologic surgery from sinus sigmoideus bleeding, or I think that even it will be functional in internal carotid artery bleeding if you put it into the carotid. So I think it stops flowing there.
What is recommendation to do tomorrow or in 2 days, 3 days, to do active suction, to use suction in the nose or nothing?
I think it depends on Honzo. Sorry.
I think a patient can go home tomorrow and.
Yeah, and when you use Surgiflo, yeah, the question was focused on.
Surgiflo, yeah. So now
we syringe.
It's absorbable, and now we rinse the nose from the remnants of the Surgiflo. I think the same recommendation like after every other surgery. So nothing. Or rinsing the nose, yeah, nothing else.
Sáni. Pak ještě vypláchnu tu klinovku. Trošku.
Yeah, perhaps we should take the opportunity that if you do sinus surgery, you have a small but there exists risk to have some kind of complication, including skull base injury or bleeding or whatever. And that's why, in principle, even if not like 50 package of everything, you should have your type of strategy and your material there existing for the case that anything happens. Okay, so if you set up your private practice, starting to do sinus surgery, look that you have some kind of like fibrin glue or anything to make a structure like Tutupatch, Dura, Duragen, Duramatrix, whatever you call it. I'm not associated with any company, but you may choose the opportunity to go outside to visit a few of the companies there to get first impression. And I think that's just similar as like we take to have our instruments and our sets and our nurses and talking about complication and teaching everybody. We also make sure that we have that stuff available. Talking about that with the nurses changing in Germany, you may happen that, somebody tells you, I don't know what that is, and I can, bring it to you, and, there are problems that you have to be aware of. So it's also possibly a sensible thing to tell you guys, if you are starting, look that you know what you have available at your place. And if it's from this year, that would be nice as well, because they are consumable.
Honzo, what are you doing with our Surgiflo?
Sorry, again?
Could
you repeat it?
Never.
I don't understand.
As you mentioned, sometimes happen, for example, the metastatic renal carcinoma, which is very bloody, yeah? And then you definitely will be happy that you have this stuff like Surgiflo, because sometimes can happen this surprise even in maxillary sinus, for example.
Why are you irrigate and are you using suction again and again? Why?
But we should syringe
we clean the nose.
It was clean,
yes.
and so.
So.
I think it looks perfect. I just have a final question with regard to the middle turbinate, because you did, quite a bit of surgery now. Do you have any gut feeling with regard to the middle turbinate and like stitching it to the septum or leaving it where it is? Is it stable? I've got no idea.
Thanks.
Honzo?
I think there isn't any problem. The middle turbinate is stable. Yeah?
Okay, thank you.
We usually put it into the position. There is some studies that are studying this complication like maxillary sinusitis after nasal transsphenoidal approaches, and it really doesn't matter if you do that or not. Yeah, there was 2 groups of patients, and in one group they put it back into the position, so they medialized the middle turbinate and superior turbinate, and in other group they don't, and nothing happened in both, or there wasn't any significant difference between 2 groups.
Achim, you would prefer to do anything?
Okay.
I think that I usually do that, but I don't think that it's important. Yeah. It depends how strong you are and how the middle turbinate is, and so on. So definitely you look there, but I think in this case, in this patient, it's not necessary, and I think everything is perfect now in the nose.
Yeah, I completely agree. I just wanted, because on one step I just had the idea that it might be slightly lateralized, and I wanted to get us all pay attention that we don't have a floppy turbinate, or, it may happen, okay, it's not a fault or anything, and that you then are aware that while packing or propel stand or suturing, just to have 3 tools available, you can stitch it, okay? Just that at the end of surgery, when you have achieved your goal, you still look around for getting your middle meatus free and stuff like that.
If you would like to medialize this middle turbinate, what material would you prefer?
Well, it depends on how floppy it is. So if it's just, little bit, you may put in a nasal packing, which is a weak type of thing.
What kind? What material?
We have Sinonit or Gale foam or stuff like that. Yeah. But if it's really floppy, so like lots of polyps in there and stuff like that, then I'll take a resorbable stitch with a straight needle and stitch it to the septum. And we have something called Cerazund there. It's similar to PDS, so monofile suture. Yeah. Similar to the one that Niels used in his open approach type of thing. Don't use any needle that's longer than 1 centimeter. It won't make you happy. Okay.
So Honzo, thank you very much.
Not at all.
I would like to invite here Simona Bolašková with her last lecture.
Well, ladies and gentlemen, I would like to start with a presentation which is following up on this surgery. This presentation is focused on fungus ball. Fungus ball is one type of paranasal fungal sinusitis which are divided into 2 forms, invasive and non-invasive. Fungus ball is one of non-invasive forms. Usually is typically is caused by aspergillus and typically affects only one sinus. The problem of fungus ball is the diagnostic. The diagnostic is nowadays based on patient symptoms, like unilateral nose obstruction or unilateral nose secretion, then on endoscopy of nasal cavity, which is typically not specific. Only in small amount of patient we can find a mycotic material. And then we have a CT scan of paranasal sinuses, where we can find signs of chronic infection, like hyperostosis or opacification of the sinus. And also we can find a central hyperdensity here in the maxillary sinus in the center of it. These hyperdensities are center of our interest because we don't know what made this hyperdensity on CT scan. So this is a single center prospective study which started in 2018 and it's still continuing. Now I will be presenting you our first result till 2023. Before a surgery, every patient undergo a CT scan of paranasal sinuses where we can find a hyperdensity. Then the surgery is performed by endoscopic way. During this surgery, we took a sample of mycotic material, as you can see on this video or the surgery before. We took a free sample of this material. One sample is for cultivation, one for histology examination, and the third one is for chemical analysis. Before this analysis, the sample undergo an X-ray where we can find a contrasting particles. That means that we found or we took the contrasting material. Then the chemical analysis is performed by electron microscope and also by spectroscopy. And now, what are the results? Till today, we have 32 patients, now 2 more during this workshop, and X-ray was positive in 80% of this patient. We don't know why the other 20% wasn't positive, but we also sent it to the chemical analysis. And what we discovered? We discovered that in every patient there is a mixture of elements and compounds, not only one compound. The most frequent compound was calcium phosphate, almost in 70% of our patients. Other things, what we can find, other compounds, was also calcium compounds like calcium carbonate, but there was also other compounds of alkaline earth metals like magnesium or barium. Here you can see a graphic image of the elements and compounds. Here on this picture is how it looks in electron microscope. There is a typical tube shape of calcium phosphate. And conclusion, we can say that the CT scan hyperdensity are caused by compounds of alkaline earth metal, usually by calcium phosphate. Thank you for your attention.
Simona, thank you for this presentation. Any questions? You discussed it, the microbiology. It was only presentation about chemical?
Yes, it was only about chemical, but I can say that we have a good work with our microbiologists because they usually found some aspergillus or mucormycosis, and I think that about 80% of our patient has a positive cultivation for fungus. So it's good work, I think.
Yeah, I think it's tremendous work and good technical setup with the X-ray before you do actually, probably it was an HLPC, high lithography polychromatography, a chemical analysis with these peaks.
Yeah, like spectroscopy.
Yeah. Well, we need to get in, yeah, my son is doing chemistry. Okay, anyway, the other thing is one confining factor that you may want to take into account as well is the microbiome, okay, which then needs a different way of processing the specimens. But while you are intraoperatively taking the swab, there are specific swabs available, and then to see like which type of bacteria, fungus, whatever, is influencing. Because, you know, microbiome has, you know, lots of publication coming out. That would be another thing that you may want to like add to your arsenal while you're already collecting specimens. So yeah, that would be just a humble suggestion. But I think the idea is completely right. And I mean, it is consistent with the literature, as far as I'm aware of, that the calcium phosphate is a majority. Now, the question is who is actually producing the calcium phosphate, or which chemical pathway or so. And that would be, you know, like the next step probably.
Can I have a question? You mentioned microbiome. It is something what we know about it, but we don't have any experience, any studies. What about your clinics? Do you have any experience? Do you have any idea how it could be influence treatment or your knowledge and approach to different diseases? What are you doing at your clinic?
Well, we don't do any research on that. I mean, there have been phases, I would say, in things that were, well, trendy is not the right word, but when it comes to pathophysiology of chronic rhinosinusitis, and there's been this extensive microbiome trend that then slowed down again, and I think it does play a role. It's probably not the central role that we thought it would have. It's definitely something to consider when you give antibiotic treatments. But yeah, we don't specifically look into it at our department.
We have a partner who is doing microbiome, and there are a few publications already available in both oncologic and sinusitis patients, where we try to get more insight using microbiome regarding the development of malignant disease, both in the sinuses and in the oropharynx, also with regard to human papilloma virus. Okay, so in terms of technical things, we searched for the processing partner first because the analysis is quite elaborated, and then you send over the specimens. It's very difficult to set it up at your own place. Happy to help. And there are, you know, the facts like smoking history or previous surgery or whatever give so many things where, you know, that the Arab milieu changes the whole stuff, and in ENT we have a different microbiome in the nasopharynx than in the nose and stuff like that. I did a review article on that one stage. That, you know, you have tremendous possibilities, but you need like 100 patients here and 100 patients there. And so we have currently oropharynx and sinusitis, and also looked at sinus cancer, but as we all know, sinus cancer is not with, you know, 100 patients here and there. So we are still collecting there to get somewhere. And also with regard to like inverted papilloma, we haven't had a look at fungus balls because they are quite infrequent, and our place would be something as a like collaborative work which would be possible, you know, yeah.
Thank you. Any questions? Karolko, ty se hlasíš? Ne. You would like to go for lunch. Yes, yes. So we are at the end of this block of presentation and live surgery. So thank you for it. Now we have break. The lunch should be prepared there, and we should start with next session at 1:15. For those who are leaving Ostrava, who have to go, there is prepared certificate for you and for everybody, also photo from yesterday. And I hope that you will still stay here for this our afternoon program. If not, I would like to thank you for coming to Ostrava. I hope that it was interesting for you, that all these surgeries. For me, it was very, very nice, and I got a lot of new information. I hope that also for you, and I hope that we meet again in future. So now we can have break.
Vicky, where are you? At first, I would like to say that every patient from yesterday's operating program is in good condition. Everything is fine, and in the morning, the patient wanted us to say thank you to the surgeons for perfect surgery. And and now we can continue with our session, which is maxillary sinus. One thing I would like to mention is if you saw tomorrow's surgery, it was a very nice picture from the data projector. Yes, so it was it was bought by our IT management from hospital for 40,000 crowns. You to have a nice picture of the surgery. So thank them. Can I have a presentation? So I would like to introduce this topic, maxillary sinus. What do you think about maxillary sinus? It's a easy sinus or not? Yes? Yes. I think that's not. It's usually the first step for young endoscopic endonasal surgeon. And definitely middle meatal antrostomy, it's an easy procedure. But neoplasma removal, it's definitely problematic. If you think that can be spread to the anterior wall, for example, and it's by endoscopic approach is, I think, the most difficult part, mostly not frontal sinus, definitely, but yes. You have to indicate, or your indication should be proper, because here can be complications. You can see here is the patient with mucosal cyst, which is here, and after surgery, I think it was in a different department, not our department. By Shaver, it was performed orbital injury, and it results like blindness. So after supraturbinal antrostomy can happen this kind of complication, as you can see here. So cyst, asymptomatic. It was during the septal, after the septal surgery, it was performed, and then surgeon tries to remove this asymptomatic cyst from the maxillary sinus, and the patient was blind on the right side. I would like to say some words about indication for surgery. I was taught that at least 2 out of 3 parts should patient have, and we can then indicate the surgery. So at first, symptomatic patient and pathology on CT or MRI, and pathology on endoscopic examination. But question is if mucosal thickening is indication is pathology, mucosal cyst, as we saw the patient before, or total opacification, or bony destruction is pathology on CT, MRI. We discuss a lot of patient, and especially, for example, if patient has a history of the cancer, does it change the indication or not? We discuss in our morning sessions with Professor Komínek. He is sometimes against our indication because he asks us, does the patient have any problems? No. Okay, why do you indicate this surgery? For example, in mycotic sinusitis, sometimes 70-year-old woman with mycotic sinusitis without any symptom, is it indicated or not? I think that yes. Sometimes Pavel believes that it is not. So, because it's now after lunch, I would like to test you a little bit and wake up with some radiological images. So, what do you think is here? And it's the same as here. And we mentioned it today. It's indicated if a patient is asymptomatic. I think that yes. Yeah?
Yeah, I'm in favor. So on your list, if you have got bony destruction, you have got a neoplastic suspicion, and I would suspect this patient to be a little bit older because apparently there are no teeth available anymore. And thinking about old patient and then, you know, bony destruction, and then this kind of image that may be a neoplasm, that may be a fungus type of thing. Anyway, try to get it out because old means immunocompromised, possibly, and then it's beneficial on the patient's right side. Yeah. Whereas on the left side, now it becomes more difficult. So there I don't have the bony destruction. Because it's the same patient, could be the same problem, and I have to speak to her or him about that. However, if it's only the left side, I would be tempted to leave it alone, okay? Just to show, I think beautifully took this case. Yeah. On the other hand, if I do the surgery on the right side, I'm really tempted to have a look at the left side.
And this is a contrast enhancement. It's a big enhancement of that. So, and it was metastatic renal carcinoma, as you mentioned, very bloody tumor in that. So, isolated maxillary opacification can be inflammation, cyst, odontogenic, or mesotoma, as we saw, or neoplastic benign, inverted papilloma, or malignant. Definitely, you have to look onto bony edges. What is in EPOS, that isolated maxillary opacification is a marker of neoplasia in 18% and a marker of malignancy in 7 to 10%. So keep it in mind that it can be asymptomatic sometimes, and it can be tumorous or even malignancy. So I skip that. We saw that, so participants, not faculty. Can somebody tell us what's that? Zdeňku. Perfect, thank you very much. This is a little bit harder to know, but it's the same patient, and if you look here, yeah, so opacification of the left maxillary sinus, and it goes to the choana. Anybody? Antroconal polyp? Yes, yes. Okay. Another case? That similar, but on the axial scan, you can see, and this all. Old, not old, but I think 50 years old man, angiofibroma. As you can see, destruction of the sphenopalatine foramen. Okay, next one. Notice this. Anybody? Inverted papilloma, perfect. Here is a MRI, which is a very nice picture on MRI. It's a very suspected inverted papilloma or cerebriform look. It wasn't asymptomatic patient, but he has hypostasia. He had hypostasia in infraorbital region. What do you think about that? Excuse me? Anybody? We thought that it's something like neurofibroma or something from the nerve. But if we look, what is important in these cases, or if you have cancer, for example, in the maxillary sinus, it's you can see V2, foramen rotundum here and here. It's a destruction, so it's a sarcomatoid carcinoma which spread along V2. Yeah? Very important thing. That sometimes carcinoma can go along this nerve. So I think we had it again. So here is odontogenic sinusitis after implant. So here it is fibrous dysplasia. And I don't know what's that, but it's, yeah, here, possibly, yeah. Again, odontogenic sinusitis. So sometimes it's necessary to look into the sagittal views in this. Okay, carcinoma, inverted papilloma, bony destruction of posterior wall, and here, in medial wall.
Petře, Professor Komínek is ready, so if it's possible, he will introduce the patient from the operating theater. He will put the picture in the corner, and you can continue with your presentation, if you agree.
Okay, I think
Či poprosíme obrázek ze sálu.
Okay.
Pavel, you can start.
Pavel, we can hear you. Can you hear us?
I don't hear you. Můžete zesílit zvuk, ať slyším ze sálu, málo to slyším. So it is the patient approximately 40 years old. Can you hear me?
Yes, we can.
And she was referred to our department by Dr. Červenka for dacryocystorynostomy external. She has bulking there. In this area, can you see it?
Yes, we can see it.
Yes. So, but there was probably bigger swelling or something. Now there is nearly nothing. Only when I palpate it, there is very soft tissue there, but no bounding. I examined this patient before operation 2 days ago, and there is normal fluorescein dye disappearance test. There is normal irrigation, quite normal position, and she had no problems with tearing. So I am not sure that there is any connection with lacrimal system pathway. So we decided to do extirpation. Yes. I don't know what can we expect. Now it looks quite different than on CT. On CT there is bulking approximately 8 millimeters, and now there is only some soft tissue, so I don't know. So you can follow me. I will, if you find that it is interesting, you can interrupt.
Patient number 14.
Yeah? Okay, and what I wanted to say that I operate now with exoscope. Can you see this?
Yes, we can see the arm.
It is something what is I am not quite familiar with, because it is for me 3D picture, and I have to look on the screen. But I will be turned with my head on opposite side than my head, so I am not able that I will be able to cooperate my brain with my hands. I am not sure. We will see.
Definitely yes, Pavel.
I have 3D picture. You should have 2D picture. Yeah.
But we have very nice picture.
So you,
2D, but very nice.
You can continue. You can continue with your presentation.
You want a presentation or surgery? Right.
Presentation. Okay. What is better for you?
Okay, I have only, I think, 2 slides, and you are familiar with this diagnosis, I think. So it's on the left side, it's mycotic sinusitis, and on the left side, the shape of the orbit can help you in this diagnosis, and it's a silent sinus syndrome. Next one, if you look at that, it's almost same as mycotic sinusitis. But if you look a little bit more posteriorly, you can see the oroantral fistula. So it's possibly here is tooth root. And yes, it is. Okay, and the last thing on the left side here, it's some malignancy, we think, because it's a bony destruction about the carcinoma, squamous cell carcinoma, and here is a very rare mucopioceal of the maxillary sinus. So keep in mind that sometimes it can be malignancy, up to 10% maybe, if you have opacification on the maxillary sinus. And even if a patient is asymptomatic, you have to have in your differential diagnosis. Thank you. And I think we will watch now. We will watch now surgery, and after we will continue with session.
For me, it is not optimal because I am sitting on the right side, and I have to prepare from upper part of this swelling. So there I feel that there is bordering. I don't know. It is there. It is probably part of it. It can be. So it is a little blue. So I don't know. Lymphangioma. Maybe. Netahejte to tolik. Gently. So very gently.
What do you think about DCR-graphy in this case?
Yes, why not? Why not? But probably I wouldn't expect that any impact for us. Probably not. But yes, but it could be done. The patient had no problems. No. It is much more anteriorly than normal position of lacrimal sac is, and maybe for you, if uvolněte to. For people, if there is horizontal in this going through this inner canthus, there is a rule that if the bulking is under this line, so in this position that it should be lacrimal sac dilation. If it is in above this portion, it should be tumor of ethmoids, but their CT is quite normal, except this bulking located on the bone, nasal bone. Maybe you are looking that I should only observe I should only observe the screen, but for me is better to look directly into the incision. It is my mistake, not the mistake of this.
The exoscope is a very beneficial tool especially for microscopic surgeons, because they don't. It's not necessary to look into the oculars, and so it's more ergonomics for you. You can sit like in a living room and look at the picture above you, and you can operate.
Yes, but it is better. It is much better for neurosurgeons for us, because when we do any surgery, we have many times rotate head, and it is not easy especially with this. It is from B. Braun company. I don't want to say nothing bad, but manipulation is, if you are not using this exoscope every day, it is not easy. It is not easy.
It's a robotic arm, so yeah, you should be trained with that, and then you are familiar with it.
Much better it is for neurosurgeon, because they have one position during the whole operation, and they don't change position of the brain.
Where it is beneficial, I think it's in surgery in pharynx, for example, for tonsillectomies. It's very nice for resection, extended tonsillectomies in tumors, or oral cavity surgery. It's very nice, very nice. And some of the exoscopes have a possibility to have NBI or something like that, so can helps you to identify edges of the tumor.
Yes, when I was in Roma for Oncological World Congress, there was special session about this exoscope in parapharyngeal tumor, and result was that if you don't have, it is not allowed nearly to do it. But our experience is not so big, of course, and I don't know if it is really in all these procedures, if it is necessary. It's like robot. Robot now, it is something what can help us, but I think that it is sometimes used only in operation where there is no benefit, except that you can say, yes, I am doing operation with robot.
I can comment. I know that in Ostrava you have this exoscope together with neurosurgeon, and we had the possibility to use several weeks this exoscope from the other companies. It was the company Olympus and also company Storz. So if I can comment, we use this exoscope for surgery on the neck, for the thyroid gland surgery, for example. We use it also for tonsillectomy, as Petr mentioned, and we use it also for middle ear surgery and cochlear implantation. So very nice is the quality of the picture, because these exoscopes are 4K and 3D. So the quality of the picture is really, really nice, but the surgeon should follow the screen. And if we see Pavel Komínek, I think that he is watching the wound directly. He is not watching the screen. Yes, isn't it, Pavel?
Yes. Yes, it is true. But maybe the problem is in my head. Yes, that if I if I use this instrument exoscope every day, maybe I would have no problems. I don't know, but I am too old to use these new things. It is for younger people.
I think that they put the screen behind your back. It's a joke.
I have one screen there. Yes, so
But your assistant follow the screen, isn't it?
I don't know.
Or nurse? So do you have two nurses or one assistant?
I should follow screen. Not my assistant. Assistant should...
But you have two screens. But Victor, are you aware of any publication regarding the learning curve sweeping from microscope to exoscope that you need a certain number of procedures done to get familiar with that also?
Yeah.
So if you compare the microscope with exoscope, I think it's different, and you should have training. But as a fast surgeon, you are able to do something with your hands and you can follow the screen. So I think that for the surgeon is the same like during the fast surgery. And we have this training.
Yeah, I remember watching people playing guitar with the guitar behind their back, and they do it as part of a rock band. And that's when you know that obviously this guy is able to play guitar. Nevertheless, in some situations, I think it's doing the easy way. Now, the exoscope is coming to Germany as well, and we were offered one. However, the price we were supposed to pay was as a market price. So you want to get access. Was in the area of I think 300 grand, and as an alternative was getting a microscope, and then the microscope had some fancy application of contrast enhancing, I don't know, and getting intravenous dye solution and stuff like that. And in the end, just because, what Pavel just said, it's a learning curve and you have to change and so. And then we had the gut feeling that we had to have quite a bit of training, okay, to get it working. And that's why we didn't got an exoscope. I don't know whether Freiburg made different decision.
We have one, and the head of our cochlear implant department, she uses it for cochlear implantation and quite likes it, especially in difficult cases where sometimes you don't have good access with the microscope, and we sometimes use it for neck cases as well.
So I am doing something, I don't know what I am doing quite, so I try to dissect slowly this soft tissue from surrounding. There are no good border, but no problems. There are no fixation, no infiltration. Yes, so I will continue, and you can follow me, and later you can go back to my operation. Yeah.
Pavel, just a question left, because I think the picture is really excellent. Yeah. Now, in this case, do you watch out for specific anatomic landmarks like the medial canthal ligament, or anything like that, or what is your orientation in this situation currently?
My orientation now is no orientation. So medial canthus, I am a little more anteriorly. Yes, I think that I should be somewhere there. Yes, medial ligament. I am. Dissection is made more anteriorly on nasal bone. It was also according to CT. So now I have still no orientational landmarks. Still not. And I think that it will be, probably I will not have during operation any landmarks. I think that I am in healthy tissue, so I have sharply, I cut it, but I still don't have any landmarks.
And now, because we spoke about the lacrimal pathway beforehand, perhaps I give this question to Petra to not keep you too much occupied. How about having like a silicone tube or anything within the lacrimal system, just to make it easier to palpate the lacrimal duct, to avoid any injury by happenstance when I come from the outside? Any ideas on that one?
Once more, please. Can you repeat it?
Yeah, because you know you're coming from the outside, and you know we all know that in the vicinity is the succus nasolacrimal sac. Putting silicone foil or tube or something in there to make it easier to be detected. Would this be more a negative thing because it's a foreign body, or would it be helpful possibly?
And where you should insert this silicone?
Like monocar into the lower canaliculi.
Like,
yes, I can. I don't know. I can insert there.
Or if you put probe there into the canaliculus and you look at that where is the sac is, and it can helps you to identify it.
But I am sure that I am still not in the sac. But I can do it. If you want, I can do.
No, it was just you know. I just want to hint at, you know, what you can think about before surgery. Now, if you are such medially, I reckon you are superficial and medial to probably the nasolacrimal sac. However, you know, most of my colleagues are afraid of, you know, injuring something and then not realizing what they have done and then getting scarring, and then because, you know, we have just talked about the problems with our ophthalmologic department, and we are causing some kind of epiphora and problems, and, you know.
Yeah.
So that goes down a difficult road for us, and one way is to put in a silicone tube, but, I mean, this may be helpful, but mustn't be. And, yeah, I just thought, you know, we discuss it well.
I still have time for it, I think. You saw a silicone tube, yes, but silicone tube you don't feel it with your palpation. You can see where I know where are canaliculi. They are much lower. I am still too far. Yes, it is much lower, and I am too anteriorly to lacrimal sac and to canaliculi.
If you would perform external sorry?
Maybe you are right. I will see.
Would you perform external dacryocystomy the same incision you would do, or in different way?
The same incision. It's nearly yes. Nearly yes. Maybe a little lower. Yes, but that's same.
Almost the same.
Nahoru zase vyše. Neroztahujte mi to tak hodně, jo? Mě to deformuje ránu. Ušky.
Well, we will continue with our program with next presentation, and we'll put you into the corner, and we will watch you. If in a case of something you want to say us or show us, tell us, please.
Yes. Okay.
Okay, so I would like to ask Dr. Mladoňová to have a speech about pathology of the maxillary sinus. Misha, please.
Thank you very much. So, pathologies of the maxillary sinus is the next lecture. First of all, maxillary sinus is a paired, pyramid-shaped paranasal sinus, which has very important syntopic relationships, as you probably know. In our daily practice, we are dealing with various pathologies of the maxillary sinus, which are often incidental, and it is very important to know the most common diagnosis. These pathologies of the maxillary sinus could be divided into internal, which arise from the sinus itself, and external, from the surrounding area. What is very interesting, maybe interesting, these pathologies are often asymptomatic because they expand to a significant size even before the first symptom. I would like to divide these pathologies into these 5 groups, but I would not deal with these 2 because here is the history clear. So, the first, inflammations. Inflammations could be divided according to the duration to acute and chronic, and according to etiology into dentigenic and non-dentigenic. And this division, we think, has clinical significance. Most important, most common and most specific of them are dentigenic and fungal, and that's why I'd like to focus on them. So the first, dentigenic sinusitis, you've heard about it today, so very quickly. Dentigenic sinusitis represents around 70% of all maxillary sinusitis, and they have typical unilateral symptoms like, for example, purulent smelling secretion, obstruction, and so on. What is interesting on CT, or what do we have to realize, is one-side opacification, and what's more, periapical process or bone defect or something like that. If you can see on CT this, and you have typical history or typical symptoms, probably it is dentigenic sinusitis. The next one, fungal sinusitis. Symptoms are very similar, again mostly unilateral, like purulent smelling secretion, obstruction, pain or pressure about the sinus. And on CT scan, what is very interesting, you can find, once again, mostly one-side opacification, which is inhomogeneous. Yeah? You can find something like hyperdensities or calcification in the sinus. And what is interesting, often you can find there something like hyperostosis of the lateral wall and usuration of the medial wall. The next diagnosis isn't sinusitis, but it has a relationship to chronic maxillary sinusitis. It is called silent sinus syndrome, and this syndrome has typical unilateral symptoms like anophthalmos, hypoglottis, and pseudoretraction of the upper lids. And on CT you can find something very interesting, and that is pulling the base of the orbit into the nasal cavity, and of course unilateral opacification. Next pathology is benign lesions. Benign lesions represent a big group of pathologies. The most common, the most typical are cysts. These cysts are mostly asymptomatic and don't require specific procedure. Enteroconal polyp is the typical and most common from all polyps, which is characterized by unilateral obstruction of the nose. So in general, benign lesions are mostly asymptomatic, or sometimes the patient can have nasal obstruction, and on CT scan you can find mostly partial opacification of the maxillary sinus. The last one group, tumors. As we have heard, we always have to think about the tumor. Within maxillary sinus, or tumors associated with maxillary sinus are both benign and malignant, and there are many different subtypes. So it's very important to think about it. Symptoms and CT scan and endoscopy findings, that's all depends on the extent of the process. So in conclusion, diagnostic procedure, most important symptoms and history of the patient, of course. Then endoscopic findings, if there is discharge, tumor polyps or something in the middle meatus, of course. And on CT, you have to find specific characteristics. And that's all. Thank you for your attention.
Misha, thank you very much. Any questions for that nice presentation, overview of pathologies? Nobody is active today? No book?
Jürgen Abrams mentioned that about 20% of maxillary sinusitis on one side are odontogenic. Do you agree with this number?
I don't agree. I'm not sure, but I think in EPOS it's a higher number, around 60 or 70%. Yes. And in our daily practice, we can see that that's the percentages.
I don't know. I think that's what is the group you compare it with. So it's a chronic rhinosinusitis.
No, we are talking about the unilateral maxillary
just
sinusitis. Just only the maxillary sinus.
So there is the discrepancy, but I think in EPOS is this number.
70. 70.
From
70% up to
60 to 70%. Yes.
Yeah, I agree.
Maybe.
And your dentist agree with you?
No, definitely not. Yeah, for them it's a problematic, and for us too. Sometimes we open the sinus and wait, and it's white antrostomy, and there is a pus in the sinus again and again and again, and then dentist consider that it's odontogenic sinusitis, so it's a big problem. But for them, it's what they can do. Usually, they have to extract the tooth, and that's a problem for patients. But yeah, sometimes it is a big problem.
Can I have a comment? Because to just complications, especially intracranial or also rhinogenic complications. Prior COVID era, we had almost all of adults. They were odontogenic complications. So especially in these cases, I would support to do really proper stomatological examination. Nowadays, there are more frequently streptococcal infections who cause complications.
You are right, but be aware we had a couple of patients too with brain abscesses or orbital complications due to odontogenic sinusitis. Okay, any other question? So, Misha, thank you very much.
Thank you very much.
And I would like to ask Dr. Lubojacký with next presentation. Surgical approaches to the maxillary sinus and overview. Jakube.
Good afternoon. So we heard about some pathologies in maxillary sinus, and now let's see how to reach them, how to get to them. So before, I would like to speak a bit about the anatomy, about two nerves that could be damaged during the surgery of a maxillary sinus. First one is nervus infraorbitalis, which is a branch of maxillary nerve, and it passes through infraorbital canal at the roof of the maxillary sinus. Usually there is no problem if it's like this, hidden in the roof, but sometimes there are variations and it could be susceptible to damage. So before surgery on a maxillary sinus, you should have a CT scan and see what the anatomy looks like. The other one is nervus alveolaris superior anterior, which is a branch from the infraorbital nerve, and it passes right at the front of the maxillary sinus, actually in between the medial and anterior wall. Yes?
Jakube, can I stop you for a minute and switch to the operating room? Professor Komínek would like to show us. Pavel?
Yes, thank you. I only wanted to show you that we inserted probe into lacrima sec. Can you see? I don't know how to manipulate with it. Can you see it? That there is a probe, yes?
Yes, we can.
Lower canaliculus, yes. And then we feel the bone, so we say that it is so-called hard stop. Chytněte to. Hard stop. And now landmarks, yes. So I said that we are anteriorly, and there I think that it is the inner canthus. There,
you can see.
Should be also anterior aspect of fossa lacrimalis, where is inserted lacrimal sac. So we are this ligament is anteriorly to lacrimal sac. So we are really anteriorly to lacrimal system. Yes, and it is we separated this upper part. I don't know, maybe hemangioma, or I don't know what it is. And now we are going in inferior direction. Yes, so you can see. You can see. I hope that it will be not necessary to do longer incision. So I will continue slowly, and you can continue with your presentation.
Okay, thank you very much.
Tak, dáme háčky.
Jakube?
Okay, so let's move on. These are the possible approaches endoscopic to the maxillary sinus. So let's start with the infraturbinal antrostomy. In infraturbinal antrostomy, you reach the maxillary sinus through lateral wall under the inferior turbinate, as you can see on the picture. It's definitely not recommended to do for functional surgery because the mucociliary transport will always go up to the natural ostium, so it will never heal if you do it for functional purposes. But it's a good possibility to have if you have pathology on the floor of the maxillary sinus, and also you have a healthy primary ostium that you don't want to damage with supraturbinal antrostomy. So in these cases, it's a possibility. Also, at the end of the operation, here you can see mucosal flap and drilled hole to the maxillary sinus. You can close the hole with the flap, and it's like you've never been there. Yeah, it will heal perfectly. Another one is supraturbinal antrostomy. That's a gold standard, probably the most used approach to the maxillary sinus. Very effective for functional surgery, so all the inflammations, fungal sinusitis, odontogenic, even chronic rhinosinusitis with or without polyps. There are 3 possible types, and they all depend just on the size of the actual antrostomy. So if it's under 1 centimeter, it's type 1. If it's between 1 and 2, it's type 2. And if it's bigger than 2 centimeters, it's type 3. Okay, so this is the place in the middle meatus where you enter the maxillary sinus. I think we've seen 3 of them already live, so I will just skip the video if I can, just to save time. And let's go straight to the sublabial approach. This one is very interesting. You go actually not through the nose, you go through the sublabial incision, as you can see on the cadaver, and you go through the anterior wall of maxillary sinus. A huge benefit is you have a lot of space, a lot of maneuverability, good overview, and you can reach all parts of the maxillary sinus, and if there's like big tumor, you can even use four-handed surgery because the hole is big enough. Also, what you can do if there's a tumor behind the maxillary sinus, or if it's growing through the posterior wall, you can take the posterior wall down, and this is the posterior wall, you can take it down, and you will gain access to the beyond the maxillary sinus, the infratemporal fossa. And you can see the sphenopalatine artery here, maxillary artery, and you can perform surgery even behind the maxillary sinus from this approach. Next one is pre-lacrimal approach. Actually, Dr. Hildebrand will have a separate presentation about this one, so I will just skip it to the video, where we operated a tumor on the posterior wall of the maxillary sinus through the prelacrimal approach. Here you can see the incision. This is inferior turbinate. We use laser, then use chisel just to get through the bone. You have to be careful not to go very in front in order not to damage the anterior supraalveolar nerve. And here you can already see the approach to the maxillary sinus, and on the posterior wall you can see the tumor. So now we'll do the tumor resection. I'll just skip it so we can see. This is resection. And at the end, you can very elegantly just close the hole that you created, put some stitches, and again, it's like you've never been there, perfectly healed. What is not so good about this one, if you have a tumor in maxillary sinus, you don't get a very good overview of the area after the surgery. You usually don't see if there's any recurrence, so you need to rely on some other methods like MRI, for example. And the last one I have here is medial maxillectomy, where you remove all the medial wall, also with inferior turbinate, and this is done only in tumors, for example, inverted papilloma or carcinomas. So this is a case of inverted papilloma of the anterior wall, and this is what it can look like after surgery. And also you can use this approach for lesions behind the maxillary sinus because you have a very wide approach. What is great about medial maxillectomy is you have a great overview of the operated area, so you can easily spot some recurrences after surgery. You can easily take probatory excision if you have suspicions that there may be still something growing on after the surgery. Yeah, this is a patient with inverted papilloma. There was some suspicious lesion. We took a probatory excision. It was nothing. It was a granulation tissue and some polyp, but it gives you the opportunity to take probatory excision. Okay, so in conclusion, maxillary sinus, it's probably the easiest of the sinuses, but still doesn't have to be always easy. So you should choose the right approach, not only based on the pathology and the anatomy, but also on your experience. And always bear in mind that the revision surgery has a lower success rate. So if you're not sure that you can do it right on the first time, and probably there's a bigger hospital near you, you can always call them and consult if it's not better to send it to higher workplace. Thank you for your attention.
Jakube, thank you very much. Any questions to Jakub's presentation? Anybody? Mm-hmm.
Perhaps just a comment, but perhaps Tanya goes for it as well. You can go to the perigopalatine fossa if you use the prelacrimal approach as well and go even laterally than the wall of the maxillary sinus. So in a way, no need to use this like Calder-Luc type of approach. That's number one. And the second thing, Peter Wormald had introduced the idea of putting the scope through a like little drill hole ventrally and then while doing surgery on some other way. And he put forward some anatomic type of analysis, how you could define the area where the superior alveolar nerve would be. And that is in alignment where in the eye, so the eye of the patient has like a bluish and a whitish conjunctivitis and the papilla or type of thing. And the medial area where the blue like starts to begin, okay, that's the line of flight where branches of this alveolar nerve are. So if you're using this approach or like a midfacial approach or whatever, this may help you that during surgery you are aware of where actually the nerve is to avoid a neuralgia because, and that's another disadvantage, after Calder-Luc you experience up to 15% of neuralgia of this nerve. So, and that's something that you have to inform the patient beforehand if possible.
Jakube?
It's not like we use the sublabial approach every day. It's only for like specific cases, like the perilacrimal approach you can't always use on every patient. It also depends on the angle, on the distance between the anterior wall and the nasolacrimal duct. So you can always combine the approaches and choose the right one for your patient.
Okay. Any other question? No? Okay. We can switch to the operating room for a second. Pavel, can you tell us what are you doing?
So I separated now this upper part of this bulking, and I am going in inferior direction. I think that definitely that it is not now a lacrimal sac. And now I try to distinguish muscles and other structures and to divide them. So, because if I push on it, so it is moving somewhere there, but I don't believe that there is continuously connection with these tissues. So I try to separate it slowly.
Is it vessel inside of that?
Yes, there, yes, you can see. I am sure that it is vessel, yeah. So I think that it is probably, I don't know, hemangioma maybe, something, but nothing severe, I think.
Where is this exoscope beneficial is during the COVID era?
I have to agree with you now. Yeah, that for you it's really much better than with endoscope and so. So better I try to support you.
Thank you. During the COVID era, you can use the protecting shield, and you don't have to be as close to the patient. So it was one reason how to perform surgery during the COVID era.
It should be for education. When I attended one ENT German Congress, I think that six years ago, there was panel about these new technologies, about exoscope, microscope, and so. It was focused that it is for education. But my feeling, and I think that the feeling of many people, was that students can stay at home and lie in their bed, and that it is not necessary we want to get new information, that it is not necessary to go to OR, that you can stay at home and only operator should be there. So but I am too old and I am really too conservative.
You are not.
I am not?
You are not.
I am in this way. You have to do something.
I think it's worthwhile because you have all this wealth of knowledge acquired in just a few times of extreme surgical experience and profound knowledge, and just this point of view gives you an advantage over all the young advancing growing surgeons and their way. So I think that in an ideal setting, you with a young person like Petya will be able to get everything out, because you can play with each other the discussions in favor and against, and in which situation and indication it actually is helpful. Whereas a young person may follow this lead where they say, if you have got a hammer, everything looks like a nail, and then they nail on everything. So use the exoscope whenever they do operate, and by this probably spend some time on just learning how to deal with things and accept that there are disadvantages. So stop telling yourself being old, Pavel.
So I think that it was inferior aspect of this swelling. So probably there is nearly nothing. What I probably will cut it, electrocoagulate and cut it there. Yes, yes. That's all. Měřítko. So I separate it. I think that it is the whole. And I will send you information what it was histologically. So you can see that it was approximately 1 centimeter plus this. I think that it is not part of it. Any questions, please?
Nobody, Pavel.
No.
Or one question.
So you expect it would be hemangioma or something different, or it's too difficult to say?
Yes, it is too difficult. Only that it was soft and that it collapsed, but the idea that it is connection or part of lacrimal system, I think that was not good. I think. So we will see. We will see. Theoretically, there can be also diverticulum. We know diverticulum of lacrimal sac. It can happen. It can make some troubles with tearing. But in this case, I don't think that it is. Now it looks all parts. It looks nearly like muscle. Nothing special. Should I cut it through? Would you like to?
Yes.
Or not? Yes?
Yes.
Achim, yes or not? What?
I'm sorry, I'm very old and I don't like to cut things. But,
you don't like it?
Because, you know, Petra is at home here, so I won't object. I reckon if you cut it through, so if you take like a knife, a scalpel, and cut it through, I suspect that you won't see much on the slide you are, doing. But just a guess.
So our pathologists don't like to cut the specimens because it's really difficult for them for orientation.
Yeah, and then they tell you you left something in there, but you didn't. And
Dobra.
Pavel, may I ask you if we can see you remove the periosteum from the nasal bone, isn't it? And is it possible to recognize the periorbit?
No, not because periorbit. It is. I am in the nose. There. You want to go there?
Yes, of course. So you should go down. You can see the periosteum in the orbit. It's a periorbit, or you can see the orbital septum. Yes. So the structures should start here, yes. So my question was that it's impossible to see just now. We should go deeper and find the structures.
Maybe yes, but I am not expert. I don't do palpebral surgery. Yes, so I am not quite familiar with this surgery, and I don't want to separate it. I don't see any reason. Yes, there it is the lower eyelid, and so he wants to.
I think it's the muscle of the lower eyelid that we are looking at, and we have the medial canthal ligament, and we have the bone as like for the operation report to be reported that we have seen them. So, and that leads us to, just discussing that if the pathology reports that something is in there, obviously inferiorly would be one direction. However, if we go in there, exactly in there, then we may have a dysfunction of the muscle if we cut it, and that's.
I don't want to do it.
So please don't cut it, don't cut it. It was just only the question. For us, for our orientation, yes. So you are more anteriorly than is the periorbit. You are more anterior lacrimal duct.
And in the bone, I get the feeling in terms of, I don't have 3D, that it actually, the bone is like having an impression. So, going away from us. Do you think that's true, or is it just, looking on the nasal bone from the side where you remove the periosteum?
It was for me question.
Yes, please.
Or no, comment. Once more, I was not concentrated about it.
You beautifully resected the pathology, and now there's one small area where the periosteum is gone. And from our perspective, or my perspective, I have the feeling that there is an impression, like a dent, okay? Towards the nose. Is that a dent, or is it just, my subjective impression, which is crap?
It is, yes.
Yeah.
When you see it, it is, yes, it is. And so, would you like, now I try again to probe canaliculi once more. Maybe we will see there something. I try to curve it a little more. Well, yes. I try to do it again. And we can look there. Hlavu. We are I am sure that we are medially to this ligament, so I don't see anything, but I don't want to be more aggressive because she has no problems with tearing, and I wouldn't like to create some problems. Generally, it should be all this probing. It should be done. It shouldn't be done if it is not necessary. So, for example, after dacryocystorynostomy, in some institution, they perform every day. They perform irrigation of lacrimal system, probing and syringing. We don't recommend it. We don't do it because each insertion makes higher risk of problems, of iatrogenic damage of this very thin mucous membrane. Okay, so we insert there only some suture, and that's all.
Okay. Any questions to Pavel?
Yeah.
No. No other questions. So, Pavel, thank you very much for nice surgery. And now we can continue. Tanya, please may I ask for your presentation about pre-lacrimal approach to the maxillary sinus.
Computer is tired as well, so doesn't want to cooperate. Yeah? Okay, excellent, great. As we've already nicely shown before, there are 3 different types of middle meatal antrostomy, which is type 1 to type 3. And this morning, you actually, like in the surgery that I did, it was actually a type 3, so I maximized the opening, because you should always, or the size of your antrostomy always depends on the nature and the extent and also the location of the lesion or disease. So the more you have to manipulate within the sinus, the bigger your ostium should be. But still, some areas of the maxillary sinus remain difficult to access by way of standard middle meatal antrostomy, and they actually require more extensive approaches. The area of the maxillary sinus that are difficult to reach via this middle meatal antrostomy have been traditionally approached via the canine fossa, and you saw this, and also by midfacially gloving approach or via standard medial maxillectomy. However, these procedures have a high morbidity rate compared to transnasal endoscopic approaches, with a rate of about 75% transient and 25% of persistent complications like pain, paresthesia, and also facial and dental numbness. Extended approaches like the posterior translacrimal approach and the prelacrimal approach that you can see here can improve access to the maxillary sinus, especially in the anterior parts and the anterolateral parts of the maxillary sinus, with preservation of functionally important anatomical structures like the inferior turbinate or the nasolacrimal duct. I put in the slide after the discussion this morning because we were talking about extending the natural ostium, and in the middle meatal and trostomy approaches you can extend the ostium in a posterior direction and also in an inferior direction. You should never extend it in an anterior direction because we know that about 1 to 4 millimeters anterior to the natural ostium will be your nasolacrimal duct. And if you put a punch in here, there's a high risk of injuring the duct. So never punch in this direction. And in this cases where we actually have to go anterior to the duct, we have the posterior translacrimal approach or the prelacrimal approach. The prelacrimal approach has first been described by Su, and it facilitates access to the entire maxillary sinus with preservation of the nasolacrimal duct and inferior turbinate, and it shows a lower rate of recurrence, especially in inverted papilloma and other pathologies, because you have more possibilities to completely remove or radically remove the pathology. In the prelacrimal approach, access is gained through the prelacrimal recess, which you can see here. That's basically the space between the anterior wall of the maxillary sinus and the anterior border of the bony canal of the nasolacrimal duct. It improves the angle of your endoscope and of your instruments towards the posterior wall of the maxillary sinus, and it enables access to the anterior wall of the maxillary sinus. You can also extend this approach by removing part of the anterior wall of the maxillary sinus up to the infraorbital nerve and perform an endonasal Denker's procedure. What you can also do is you can remove the medial wall of the maxillary sinus completely. So you can perform a medial maxillectomy with preservation of the nasolacrimal duct and the inferior turbinate. So what are the indications for this extended approach, like the prelacrimal approach? The first indication would be extended surgery for chronic rhinosinusitis with nasal polyps, and we've heard about this reboot surgery before. In these patients with chronic rhinosinusitis with nasal polyps, we know nowadays that we have a type 2 inflammation of the paranasal sinus mucosa in most cases, and studies could show that a more radical surgical approach can improve outcome after surgery in the severe cases. The principle is to maximize the openings to the sinuses and to remove diseased mucosa in the maxillary sinus, frontal sinus, and the ethmoid to reduce the inflammatory load and to gain access for topical treatment, which is another important point. To achieve this, extended approaches are necessary, and you can use the prelacrimal approach to the maxillary sinus, which you can see here. Most of the mucosa has been removed. There's just periosteal layer left. And this reboot would include phaneoethmoidectomy, middle meatal and trostomy type 3, or a prelacrimal approach. In the complete reboot, you would do a draft type 3 as well. We would do partial resection of the middle turbinate, resection of the mucosa. And the literature could show that there's a recurrence rate of 8% for the full reboot surgery versus 17% for partial reboot without type 3 versus 45% recurrence rate in conservative surgery. The next indication, and I think that would be the more likely indication that we have for everyday cases, would be resection of benign tumors, for example, inverted papillomas, where it's very important that you have access to the pedicle of the inverted papilloma to do radical resection in this area to prevent recurrence. Fungus ball, where it's important, as we saw in the surgeries yesterday and today, to remove all of the fungus material. Enterocorneal polyps, osteomas, odontogenic cysts, or mucoceles. Some authors have also used the prelacrimal approach to gain access to the orbital floor, like Thomas Kühnel has described, to do a reposition and reconstruction of the orbital floor. And you can see it here on the left picture. We have the fracture here. In this area, that's the nasolacrimal duct. So this is the floor of the orbit, or the roof of the maxillary sinus from where we look at it. and you could put implants in. The disadvantage is that the maneuverability of your implants that they want to put in is quite difficult. So you need to have a bit of experience to be actually able to put one in, and also there are no pre-formed implants that you can use through this approach. Also lesions in the pterygopalatine fossa, as Achim has mentioned before, and the lateral recess of the sphenoid sinus and the infratemporal fossa can be approached via the prelacrimal approach by removing the posterior wall of the maxillary sinus, transposition of the contents of the pterygopalatine fossa in a lateral inferior direction, and then you can gain access to the lateral aspect of the sphenoid sinus, where, for example, an encephalocele, like in this picture. So we have the lateral recess, we've got encephalocele here, and we need to resect that and do a dural repair. So via the standard approach, you can't really reach this lateral aspect, but if you go via the prelacrimal approach, posterior wall of the maxillary sinus, you have kind of a straight direction to work in this lateral recess. Now, Simon has proposed a classification for the prelacrimal recess to assess the feasibility of a prelacrimal approach. They measured the distance between the anterior wall of the maxillary sinus and the anterior aspect of the bony canal of the nasolacrimal duct, and they proposed 3 different types. Where in type 1, this distance is less than 3 millimeters, in type 2 it's 3 to 7 millimeters, and in type 3 it would be more than 7 millimeters. In type 1, the prelacrimal approach would be or would involve removal of bone around the circumference of the nasolacrimal duct, and also medialization of the duct and the inferior turbinate. But still, the prelacrimal approach, if you do that, is possible. Yeah? So it's not impossible to perform a prelacrimal approach in patients with a type 1. It is quite difficult if the angle between the medial nasal wall and the interior wall is also quite steep. Then probably the prelacrimal recess is not the best approach to go for. Different modifications have been proposed in different papers to safely remove the bone around the nasolacrimal duct before medializing it in a type 1 or 2 situation. But as I said before, it is still possible to do the prelacrimal approach in these cases. So what's the technique? I want to show the different steps now. So there's an incision, a curved incision in front of the head of the inferior turbinate towards the nasal floor, which you can see here in this intraoperative picture as well. Then the mucoperiosteal flap is raised in a posterior direction to get to the bone where the inferior turbinate inserts into the lateral nasal wall, and you can see this here, that's the turbinate bone. Then a chisel is used to interrupt the connection between the inferior turbinate bone and the lateral nasal wall. And usually you have a fracture line that is actually at the anterior wall of the nasolacrimal duct. And like this, the nasolacrimal duct can be exposed, and you can see the nasolacrimal duct here. Then the nasolacrimal duct inferior turbinate flap can be medialized, and by this you can start your dissection posteriorly. You see the bony wall of the bony medial wall of the maxillary sinus here. You can then open up this wall and get into the maxillary sinus. You can remove the bone, depending on the extent of the disease and the location of your disease. You can remove it up to the anterior wall of the maxillary sinus, and also remove part of the wall of the anterior wall of the maxillary sinus, as I've shown you before. It has been said that it's difficult to access or to control, to follow up the maxillary sinus after tumor removal if you just do this approach. You can prevent that by also performing medial antrostomy, because then you can get into the maxillary sinus, for example, with a flexible scope, and you have a great overview even after surgery. The flap is then repositioned and sutured back to the lateral nasal wall with 1 or 2 sutures, and it heals really, really well. So what are the complications of the prelacrimal approach? Obviously, we work around the nasolacrimal duct, so there's always the difficulty or the danger of hurting the lacrimal drainage pathway, which can result in epiphora. Which can be temporarily or permanent. So I always consent my patients for DCR as well, but I've actually never had problems with this. But the patient has to be informed that it is possible. There can be some bleeding, there can be infection. If the anterior wall of the maxillary sinus is also resected, then there can be alar retraction afterwards, and there can be, as we heard before, paresthesia of the anterior superior alveolar process and teeth. In most cases, it's actually not due to the access itself, but due to the drilling that we have to perform. If we have an inverted papilloma, for example, that is adherent to the anterior wall, then we have to drill the anterior wall, and then by that we hurt the superior alveolar nerve. This is, for me, I want to thank you again for your attention. And I'm open to questions.
Tanya, thank you for your very nice lecture. Any questions?
How frequent do you use this approach in your department per year?
I wouldn't say per year. I probably use it once or twice a month. I have to say that we have, and I don't know why, but we have loads of inverted papilloma in our department, and a lot of them arise from the maxillary sinus, and if they arise from the anterior wall of the maxillary sinus, I always use this approach. Also, if it's in the posterior lateral part of the maxillary sinus, it's also, the angle is better for the instrumentation. Sometimes you have to combine it with the transeptal approach for better angle of your instruments. So I actually use it quite frequently.
Do you have any problem with necrosis of the head of inferior turbinate?
No, never seen it. Mm-mm.
What for foreign bodies in the maxillary sinus, do you use it?
You can use it. I've never used it for that, or I never had one there. But the nice thing about this approach, you can, like all the recesses that they sometimes have, and that can be quite deep. For example, the alveolar recess, and there could be foreign body after tooth treatment, dental treatment. You can reach it via this approach quite nicely as well.
To say that I have problem for to find the indication for a pre-lacrimal approach. For example, inverted papilloma, for me it's problematic because its origin usually on lateral wall, yeah, mostly. Yeah. So you use it only for papilloma where pedicle is inside the maxillary sinus. Yeah.
Well, I use it. When I always do a standard middle meatal antrostomy, and if I can't have enough, or if I don't have enough access to the pedicle, I always convert to the prelacrimal approach. I consent my patients for that, and I talk to them about it, that we might have to switch to this approach. And yeah, it works well for that.
What do you think is main advantage of this of this perilacrimal approach, because middle turbinate, I think, yeah, this you save and part of lateral wall, but for me, for example, cut the nasal lacrimal duct and perform the cryocystorhinostomy in these cases, it's not a problem. And after that,
but why should I cut a duct if it's not involved in disease? And that's the point, because I can preserve structures that are not involved and that are functionally important, like the nasolacrimal duct, like the inferior turbinate. We know that it's important for nasal function, and I can preserve all these structures. Obviously, if they're involved in the inverted papilloma, I have to resect it.
You are right, but in type 1, for example, the removal of the bone around it takes some time and it prolongs the surgery.
It takes a bit of time, but if I do the DCR, it will take some time as well.
Okay.
What is your alternative approach? So if you don't use the prelacrimal approach, okay, and then do you go via canine fossa?
No. Like if we want to, we perform usually medial maxillectomy.
Okay,
yeah?
but in medial maxillectomy, you're not going to. So complete medial maxillectomy and DCR, and that's how you then
for inverted papilloma, which is usually from lateral wall. That we have a papilloma from maxillary sinus is for me rare. I don't know what's your.
So I personally don't need to have the attachment of the papilloma in the maxillary sinus, but just like yesterday, I start surgery and then I got a specimen, and the specimen says I have extension into the maxillary sinus, okay? And if there is like polypoid tissue or whatever, I don't know where it is or not. So I'm going to drill out the whole type of sinus, and I want to preserve the inferior turbinate, and I want to preserve the nasolacrimal duct, and that's the situation where I would use that. I've already used it in type of lateral mucocele or mucocele after Caldwell-Luke approach, where the maxillary sinus becomes really, really tiny, and you can then like do inferior and superior, and it's difficult, okay? So, and I'm happy to use whatever comes along. And my chairman was quite skeptical as well, saying you're just playing around type of thing. But when she saw that the patient are well treated and they don't have a neuralgia or something, and they have less crusts and better looking mucosa endonasally, I don't know whether there's no controlled study. So that was when we are able to get up the work, and we weren't quizzed every time how we do it. And now it's part of our informed consent procedure to give out the possibility. Now, if you see really, you make a complete Denker and everything, like, then the inferior turbinate is normally gone as well. And then you really, I mean, the picture of Jakob was really nice, but you want to preserve the inferior turbinate and everything, and you know that the maxillary sinus gets smaller and patients still have some kind of problem there. So that's why I think if you can preserve the medial wall or parts of it or whatever, that's nice. And you have to admit, or at least in my hands, that the ventral part to the nasolacrimal duct, that will occlude. So there is no window there. For the postoperative course or care looking follow-up, whatever, you still go through the normal middle meatal antrostomy.
And also, I think for cases where you where the maxillary sinus is just basically the way towards pathology, like in the infratemporal fossa or pterygopalatine fossa, and cases like the encephalocele in the lateral recess of the sphenoid sinus. Because if you go, if you give this patient to the neurosurgeon, well, we work with a neurosurgeon and we did this case together. If they go externally, they have to lift the temporal lobe, and the temporal lobe doesn't like that.
I would use the transpterygoid approach, like only so open maxillary sinus a little bit more down, and then I would go directly there to the lateral wall of sphenoid in our way. Not prelacrimal. I think that it's a better angle for doing that.
It depends how lateral your pneumatization is, because otherwise you have an angle which is not very nice.
Definitely, it's for behind the maxillary sinus. It's a perfect approach. You can look by flexible endoscope there, but there is a problem with taking a biopsy after.
Yes.
Yeah. So the patient has to undergo to the anesthesia, or
I'd rather. Well, if I have a case where I have something in the anterior part of the maxillary sinus that I can't reach for biopsy, in some cases you can still use it with a Heuwieser, for example, even if without anesthesia. And if I can't, I would first perform an MRI scan maybe to see what it looks like in the MRI. And then we can still do a surgery and plan the surgery by complete removal. I've done it in a few cases where I said to the patient, well, we don't know for 100% for sure if it's recurrence or not. And we put them under anesthesia, we did the complete removal, and then didn't have to do procedures.
Maybe I'm old and conservative. Yeah. Thank you very much for your presentation. Very nice. Thank you. And may I ask Professor Chrobak for a last presentation of this session, external approach in endoscopic era, when and how?
Good afternoon again. So, external approach in endoscopic era, when and how. It's a nice topic which was done to me by Pavel and Petr. And when I'm thinking about this approach, nowadays everybody who is talking about this approach probably is a zombie. Yes? So just now I'm the zombie in front of the audience. Isn't it? No. So we will try to discuss this topic a little bit, and yesterday we talked about the future of rhinology, and we discussed if we use the biological treatment or surgical treatment. And if you follow this last 30 years, we started with external approach. Everything was changed with endoscopic approach, and everybody was thinking that with the endoscopic approach we will have no recidived of chronic rhinosinusitis with polyp. And during several years we saw that we have the recidived. After we used the intranasal steroids, and we were also happy, and we were thinking that nobody will have the polyps. And we have the polyps again, and now we have the biological treatment. So we can follow 3 or more revolutions during the 30 years of rhinology. So it's really interesting, and if we go back to the external approach, you can see that this name, and we know this approach as a like Caldwell-Lick approach, but this approach was also described a little bit earlier, and also one guy from Great Britain. So this approach means anterior antral window for surgical extirpation of mucosa and disease in the maxillary sinus with inferior meatal antrostomy. So we are going through the anterior wall. This guy described this approach in 1893 and 1897. And here is the approach through the canine fossa puncture. So you know that you should preserve the mucosa nearby the teeth, and you should preserve the third teeth, and you remove the all mucosa from this approach from the maxillary sinus if we have indication for chronic maxillary sinusitis, we should preserve the infraorbital nerve. And at the end of the surgery, we did the inframeatal antrostomy, and we put the flap of mucosa from the nasal cavity to the maxillary sinus, and the idea was that everything will be healed by this mucosa in the whole maxillary sinus. Nowadays, we can use the endoscopy through the anterior wall, which is see here, or we can do the endoscopy through the infraturbinate approach, like a maxillary lavage. And there are the list of indication for Caldwell-Lick surgery, which was described in 1995 in the surgical book, which was written by Naumann, and you can see a lot of indications. There are the list of this indication on CT scan and histological examination, so chronic rhinosinusitis, aspergilloma, antral cyst, antrochoanal polyps, atelectasis of maxillary sinus or silent maxillary sinus, and also the approach to the fossa pterygopalatina or fossa infratemporalis, which was mentioned several minutes before. So just now with endoscopic approach, it's a big jump, and nowadays we have different view to the same maxillary sinus, and it's like in the normal life, we can see different situation in our life. Or it's like a fun when blonde lady has a problem with her car, and she's calling to the service, and there is a recommendation change or look if you have oil, and she's not able to find the approach to the oil, yes, because there is written the number 710, and if you change your thinking, you can find the oil. And it's the same like external approach to the maxillary sinus and endoscopic approach to the maxillary sinus. So if you go to the history, they were able to go to the maxillary sinus through the nasal cavity, and you can see that they know the approach under the middle turbinate or superior to inferior turbinate, and they have no optic, and I think they know very good the anatomy of the lateral wall, just now we. So there are the indication for Caldwell-Lick approach or anterior wall approach nowadays. So sometimes we can discuss unsuccessful phase, but nowadays probably it doesn't exist. If you have problem with chronic rhinosinusitis, you can use the biological treatment now, but we can use it for some tumors, and if the tumor is in the contact with the alveolar process or on the medial wall, but Tanya mentioned just now that we can use the pre-lacrimal approach for this tumor or some foreign body, but we are able also to remove this foreign body from the other approach, fungal disease, access to the pterygopalatina fossa, or surgical repair of the trauma of the floor orbit, but we can also use the other approach. So it depends on the surgeon, it depends on the department. If we use the classic Caldwell-Lick approach, we should know this technique, and I described this technique. Nowadays, we can combine approach through the anterior wall with middle meatus antrostomy. It's also possible. And there are the landmarks, which was also mentioned, and radical antrostomy. It's a classic Caldwell-Lick approach, and this approach was modified. For example, here is the osteoplastic antrostomy, so it means when we elevate the bony part from the anterior wall, we preserve the periosteum, and this bone is on the periosteum, and we are able to put this bone back like a flap. If we make the Caldwell-Lick approach larger, it's called Denker's surgery, so there is a communication between the maxillary the sinus and nasal cavity. It's a Denker approach. Or you can see here it again, yes, and here is the inferior turbinate. And we can also use the mid-facial deglowing. So it means that incision is on the both sides and you elevate the soft tissue from the nose and you can have approach to the nasal cavity and both maxillary sinus. So this approach is also described and they use it, for example, for angiofibroma, but nowadays we don't use this approach. Some notes about the postoperative care. It's written here. And of course, every surgery can have any complication. So in the literature is written that significantly more morbidity is after this external approach than FES surgery. So about 20% can have this complication, and there is a list of these complications. And if you follow the literature, you can see that some people use this external approach with some success, and sometimes you can see that the success is better than FES surgery, so probably if this approach is more radical, so it's a topic for discussion. So if I can conclude, Caldwell-Dick approach or external approach to the maxillary sinus exists also in nowadays, and we should know how to do it. The classical Caldwell-Dick, it means that we remove all the maxillary mucosa, and this approach can have different type of morbidity as a problem with facial sensation. And if we have good indication, we should have good outcomes, so it's true for every surgery. And nowadays we should use different type of approaches as is demonstrated during this session. So thank you for your attention.
Victor, thank you for a nice overview of external approaches to the maxillary sinus. Any questions for that?
Yeah, I would like to stress the importance, because with all the techniques, while we are leaving this as a first line treatment, okay, we still have the patient, and especially if we have neoplastic lesions or so. And I was just thinking about otologic surgery, okay. Rhinology started with microscope, then went to endoscope, now going to whatever minimal invasive. And otologic surgeons, they started with microscope and still are sticking to it, and nowadays just getting to the endoscope, okay? And now we have the problem that the older approaches are not that frequently taught, not that frequently used, and it's actually a kind of specialized expertise to be able to also know when the outer approach would be possibly better. Denker is 1920 or something. So it's 100 years now, and still his name stands there with good reason. And then you have the problem of how do you reconstruct after Denker and stuff like that. So because you just introduced yourself as topic of dinosaurs or so, I don't think so, okay? And perhaps in terms of also, thinking about a topic for next year or whatever, the combination of endoscopic techniques and transfacial techniques, especially in skull base and frontal and maxillary and neoplasmal, so is something which we often forget. And then everybody has it's 2 to 5 or 10 cases a year, and then it's really important for the patient that somebody does it who has done or seen or whatever, teach it before. See one, do one, teach one.
I absolutely agree with you, yes. So if we are thinking about the history of the rhinology and you compare the situation with the otology, so if you go back to the history of otology, the otosurgeon started with canal wall down technique. And after we started canal wall up technique. So, and question is, if somebody use nowadays the canal wall down technique, is it bad or not? We should know all this technique, and we should use this technique correctly to the patient, correctly to the situation. Nowadays we can use the endoscope for ear surgery, so it's possible. But if we are compare the ear and nose, we discuss as a FES surgery pathophysiology of osteomeatal unit. And we recommend to open just only the orifices, and every mucosa will be healed. And if you compare with the ear, are we able to open the Eustachian tube? and prepare the situation for healing of chronic otitis without the cholesteatoma? It's a question. But it's nice to think about that.
Yeah, well, I wouldn't go for the Eustachian tube because that's like the Bahama triangle in like otologic surgery, despite the fact that near Münster there's something called Bielefeld and they invented the balloon, and we'll see where we are heading at with that, also with cost effectiveness. However, Plester was the one who in a way translated it and said there's no need to like open up like everything, but just the antrostomy, enlarge the antrostomy, and which way ever from like canal wall down, or an antrostomy via the outer meatal ear approach, or two ways of addressing the middle ear. And by doing that, you will then avoid having recurrent disease in the ear if the tympanic membrane works. And the Eustachian tube, I won't solve it today.
It's a really difficult
nevertheless,
story.
it's the same story that you're coming from more aggressive, like, Klei and other guys in Germany, and Woolstein, and then Plester said, be a bit less aggressive. So a similar development in some stages.
Yeah. Thank you.
Any other questions? No? Victor, thank you very much.
Thank you.
So I think that we can close this session. Thank all presenters and all discussers. Thank you very much. And now it will be break. How long? 5 minutes? Vicky told me 5 minutes. So 5 minutes.
So, ladies and gentlemen, I am happy that you are still here and not at home. And we have a last session. So I would like to invite here Lenka Chabalova and with her lecture CSF leak diagnosis. And then we will I think the discussion will be after we will see. So you can start.
Good afternoon, ladies and gentlemen. I will have a quick overview of the causes of the CSF leak and diagnostic methods. CSF leak is, in most cases, spontaneous, or it can be traumatic. Of course, in a lot of cases, it's us who cause CSF leak. And the spontaneous CSF leak can be caused by different pathologies with increased CSF leak and also increased CSF pressure, and with normal CSF pressure. What we see maybe the most frequently are congenital pathologies such as meningoceles and encephaloceles. In this list, there is not one cause of CSF leak is not listed, and it's CSF leak which is pharmacologically induced. So this is a problem mainly for the endocrinologists who treat prolactinomas with cabergoline. So this is one of our patients with KNOSP4 prolactinoma, which shrank due to cabergoline very quickly. In about 3 weeks, she presented with a CSF leak. So this is also one of the causes of CSF leak that should not be forgotten. Diagnosis, what is very important is the patient's history. The patient complains of unilateral serous secretion, usually unilateral, and also rhinoendoscopy. But in this case, patient's history is crucial. If there's suspicion of CSF leak, we confirm it by laboratory examination if it's possible, and radiology to locate the place, the area of the skull-base defect. And what also helps us to diagnose the exact place is intrathecal fluorescein. Scintigraphy here, it's only in gray letters because it's probably a historic method and we don't use it anymore. So what about the patient's history? Okay. This lady presented with unilateral CSF leak. As you can see, the patient frequently complains of the secretion when they flex their head, or what they frequently say that they wake up with a wet spot on their pillow. But this can be tricky because the secretion from the nose can be intermittent. It doesn't have to be all the time. So when the patient presents in your department without a serous secretion at the time, it doesn't mean that he or she didn't have it before. We should look for a history of some trauma, but not only cranial trauma, but also seemingly minor injuries. We had a patient that had CSF leak after a nasogastric tube insertion, and also in the literature quite recently there are cases of CSF leak after COVID-19 swabs. So seemingly minor injuries can lead to CSF leak too. What is very important, the history of meningitis. The patient with repeated meningitis, mainly pneumococcal meningitis, is always suspect for CSF leak that hasn't been diagnosed because, as I said, it can be intermittent. The patients can be treated mistreated for chronic rhinosinusitis with throat secretion for a long time. And the first thing that makes you think of CSF leak are the repeated meningitis episodes. And of course, if the patient has some history of intranasal or skull-base surgery, that is the easy one. In rhinoendoscopy, it's not that simple, but this case, this case is quite simple. It should be a video, I'm sorry. Oh, okay. Because this is a patient after resection of the tumor of the skull base. So when she presented with serous secretion, the diagnosis was confirmed when she stepped inside the door. So as you can see now, she is doing Valsalva maneuver, and this is the defect of the skull base, and it's filling with the CSF. But there are patients that are not so easily diagnosed. This is a patient that had a history of repeated meningitis. And when we performed rhinoendoscopy, the first thing that we saw was this. That's a secondary diagnosis. She had also inverted papilloma. But what do you see here? It's pulsating. The septum should not be pulsating, of course. So this is the first thing, but never, she was never treated for some serous secretion from the nose. And when we go forward to the other nostril, this is a thing that can be overlooked very, very easily because we have to go behind the septal intumescence to see the meningocele itself. So it's very narrow space, but if you wait, you will see. So here it is. This is the meningocele. So as I said, this patient, she had repeated meningitis, but only after she had meningitis twice, we thought of CSF leak. Laboratory diagnosis. Beta-trace protein is the main compound that we examine. Its level is very low in the serum and very high in the CSF. It is favorable for us because it's stable in room temperature and can be frozen. So that means if you have a patient in risk of CSF leak, you can give him a sterile tube for home, and if they experience some serous secretion, they can bring the secretion to you, and it can still be examined. So it's not the case of beta-2 transferrin because it's not stable. What is the problem with beta-traced? You have to have at least 0.5 milliliters of the fluid, and it has to be a serous fluid. So if there's mucus, if it's thick, they cannot do the examination in the laboratory. So of course, such a patient should undergo some radiology examination. Sometimes the HRCT helps you only a little bit because you can see only some fluid. Sometimes even the cysternography doesn't help you and you just see fluid. But sometimes what really helps you is MRI. So here you can see a really small meningocele that was a cause of CSF leak in this gentleman. So what we do routinely in every patient with already confirmed CSF leak is intrathecal application of fluorescein. It's administered through spinal tap, but in the Czech Republic it's off-label application, although in the literature the complication rate is reported just minimal. We have great experience with it. We haven't had any complications due to intrathecal fluorescein application so far. We use it in general anesthesia, and at the same time we locate the place of the CSF leak, and subsequently we manage the patient surgically at the same time. But of course it is also feasible in office to trace the place of the CSF leak, but we haven't done it so far in any of the patients. So, this should be a video. So here you can see that we can only suspect that there's something in the CT in the ethmoids, but this is the intraoperative image, and as you can see on the left side, we saw the fluorescein flowing just immediately. And this is after ethmoidectomy, and here you can see the defect in the ethmoids that was then repaired with fat plaque and modified nasoseptal flap. So my take-home message is, of course, any unilateral serous discharge is always suspect of CSF leak. And what is crucial is patient's history, even minor trauma, and always think of the patients with meningitis. Beta-trace protein, you can give the patients the test tubes at home. And the most reliable method, although it's off-label, is intrathecal fluorescein. Thank you.
Lenko, thank you very much. And because I would like to finish our course in 3:30. So, Honza Hanak, you have 3 minutes.
Thank you very much. 3 minutes. Okay. I would like to tell about spontaneous cerebrospinal fluid leak. Cerebrospinal fluid leak we can divide into are classified such a not traumatic and traumatic. Non-traumatic cerebrospinal fluid leak can be spontaneous in absent of obviously case such a skull-base abnormalities, bone erosion related of muscle lesion or hydrocephalus. Idiopathic intracranial hypertension is associated with spontaneous cerebrospinal fluid leaks. And a diagnosis of idiopathic intracranial hypertension is defined if the patient fulfills criteria A to E: papilledema, normal neurological examination, normal brain parenchyma on MRI, normal cerebrospinal fluid composition, and elevated intracranial pressure. Idiopathic intracranial hypertension causes the cerebrospinal fluid leaks by increasing intracranial pressure. There are 2 mechanisms by which the intracranial pressure increases impaired cerebrospinal fluid absorption and increase in cerebral blood volume. The higher intracranial pressure leads to thin skull base and over time and leads to development of meningoencephaloid cells. Yeah, symptoms of idiopathic intracranial hypertension: headache, balance problems, and visual defects. The diagnostic algorithm of cerebrospinal fluid leaks includes beta-2 transferrin test, beta-trace protein test, intrathecal injected fluorescein during the surgery. CT scan shows thinning of the skull base, multiple defects, and arachnoid pits. MRI can show encephalocele, empty cella, dilated optic nerve sheets, tortuosity of the optic nerve. Cerebrospinal fluid leak should be closed as soon as possible. We should locate the site of the leak and remove mucus around the bone defect and intersect meningoencephalocele if present. We can use a lot of materials and method for closing the defect. The patient with intracranial idiopathic hypertension should lose weight. If the patient suffers from bad vision, we can use acetazolamide, or we can do the lumboperitoneal or ventriculoperitoneal shunt, or optic nerve sheath fenestration. Thank you for your attention.
Honzo, thank you. Thank you. And now I would like to ask Petr Matoušek. He's expert in these things. Only for normal ENT doctor, can you say the most important key points with this topic? What should we avoid? What should we do? When should be a little nervous in our office?
If you don't have experience with closure of CSF leak, sent to somebody who has. The first. Second is about diagnostics. So unilateral rhinorrhea and history of meningitis. Is suspicion for so you have to examine the patient. What else?
Unilateral rhinorrhea and no history in meningitis. But
history of meningitis and trauma, CSF trauma or surgery. Yeah, it's another.
Can we wait? How long can we wait? If there is the rhinorrhea, unilateral, if there is history of surgery.
I think immediately.
What to do immediately?
What to do? To collect the fluid and send it to the laboratory, and you find out if it's CSF leak or not, and then you send the patient somebody who can close it.
If we are not able to collect this fluid.
If we are not collect, then CT or MRI or intrathecal fluorescein. Sometimes we had the patients with recurrent meningitis, and she doesn't feel any water rhinorrhea from her nose. And she had a meningoencephalocele, so it can happen too. Yeah.
So do you recommend antibiotics as a prevention of infection?
It's a tough question because nobody proved that it works. But I think that nobody from us, don't give them to the patient from medical legal reason. If something happens, then it's worse. But
I didn't understand. So if we know that it is yes,
it's no evidence that you should have antibiotics. What you what you should is vaccination against pneumococ. That's definitely the thing you should do.
What I find quite helpful as well is because some patients, they don't have a really profound rhinolicoria and they can't collect the fluid in a tube or something. So what we have done, and we've been quite successful in some cases, is that we put some gauze swabs inside the nose for half an hour, and then send this to the lab. They put it in the centrifuge and get the fluid out, and then they can do the beta transfer in on that. So I think, I don't know if your lab does it, but I think it's quite helpful.
We tried it, and our lab no
Yeah,
way.
we have the same problem with our lab, but we had another problem in a court case we came across when, you know, university used Merocell in this case. There's a publication around from Austria that apparently Merocell should like interact chemistry like with beta transferrin or whatever it was, and then they said that even if you use this, it's not, the art, you should use it because you get a false negative type of thing. It wasn't actually helpful because the author didn't respond to providing the data that, it was only his opinion, but just to, mix everything up a bit more. So using gauze is fine, but polyvinyl acetate or Merocell apparently is not. Okay, and now with regard to the antibiotics, I've just reviewed a doctoral thesis analyzing skull-base surgery, including work on the hypophysis, okay, where they used single-shot antibiotics just during surgery, in contrast to literature-reported infection rates and stuff like that. And depending on how long you operate on and some other factors, you get in subgroups up to 20% of meningitis, so quite a risky type of thing. However, in just normal hypophysis surgery, and if you just, stuff up a small leak or so, single-shot antibiotic seems to be reliable and fine. The bottom line being, if you do a real resection, if you do real skull-base work, if you do real meningoencephalocele and it's large and it takes long, and so go for antibiotics. However, it's just a tiny bit of, iatrogenic, check, and then you repair it immediately, single shot, and you should be fine in the majority of cases.
Yeah, I think that the question about antibiotics was about if we have a diagnosis of spontaneous CSF leak and you plan surgery in 3 weeks, 4 weeks, for example, because sometimes it happens that we don't have time for that or place. So about that, single-shot antibiotics definitely, and if you are intracranially, we put packing into the nose for 5 days, then we use antibiotics for 7 days, I think.
The packing is no argument for us anymore to use antibiotics. So it's only like the size that we have reconstructed and the duration of surgery in terms of, getting through the nose into brain area 1 to multiple times, okay?
But we don't have problems with meningitis. I think it's less rate than if you go with open approach, definitely through the nose.
Thank you. So I definitely interrupt your discussion. So I visited many times Germany, and what was for me shocking when I was there for the first time, when they organized event 3 days long or 4 days long, they had schedule with many lectures. Each lecture was on precise time. Yes, there was no movement. They didn't start earlier. They didn't finish. No lecture, no surgery, nothing later. So we are not so good in Czech Republic because we are late now 3 minutes. So I have to apologize. We are at the end of our course. I would like to thank you for coming here. From my point of view, I think that everything was going very well. So I would like, at first, I would like to thank our staff, doctors, nurses, technicians, and all around. There were really a lot of people, you haven't seen them, but when you are at OR, there are many people and everybody is concentrated on this topic, and it wouldn't be possible to do it without them. Second, I would like to thank all people coming here for and having here a lecture. So I start from lady, Tanja Hildenbrandt. Achim Boyle. Viktor Chrobok. Honza Vodička. Honza Hanák. Petr Matušek. And other young colleagues from my staff. I don't know what about next year, because I am tired from this organization now. But when I see that some of you are satisfied that it was beneficial for you, it is very motivated for me, and I will see. Maybe now I am on my knee, but maybe I will be able to stand up again. So I will see. I wish you a good journey. I hope that your referential, that your departments will be good, that you will discuss these topics with your colleagues. You inform them what you had seen there, and that you will have Ostrava, Black Ostrava, Industrial Ostrava in your memory. I wish you all the best and see you, I hope, next year.
Let me allow, I would like to thank Pavel and his team on behalf of our society, because I think they organize excellent course with life surgery, and we are very happy that we can be here. Thank you so much. And please organize it next year.